Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. So let me introduce myself. My name is Marsen Isbayu-Putra. I'm an occupational medicine specialist, and I will be your host today. So welcome to MACROW, Multidisciplinary Approach of Chronic Pain Among Workers. This webinar is collaboration between Perdoki, Prodi MKKFKUI, Prodi PPDS Kedokteran Okupasi, Departemen Kedokteran Fisik dan Rehabilitasi Fakultas Kedokteran Universitas Indonesia, University Medical Center Groningen, Nederland, dan juga IMERI. Terima kasih atas kehadiran rekan sejawat sekalian. Sebelum kita memulai atau masuk ke dalam sesi utama kali ini, maka kita dengarkan sambutan dari Ketua Panitia dari MACROW kepada Dr. Astrid Sulitsomo, Spesialis Kedokteran Okupasi, MPH. Saya persilahkan.
Terima kasih, Dr. Marsen. Assalamualaikum warahmatullahi wabarakatuh. Excuse me, distinguished speaker, I will just greet the participant first before coming to you. Jadi pada siang hari ini kami mengadakan webinar yang berjudul Multidisciplinary Approach of Chronic Pain Among Workers, yang merupakan kerjasama antara pihak, saya nggak sebut satu-satu ya, Universitas Indonesia dengan UMCH ya. Dan kita harapkan ini adalah yang pertama dari sekian banyak mungkin rangkaian kegiatan yang akan kita selenggarakan bersama. Terima kasih atas partisipasinya pada hari libur, bulan puasa lagi. Mudah-mudahan akan bermanfaat bagi kita semua. And to our speakers, and also I see there are other participants from Holland also, I say welcome to this webinar. I'm looking forward to this seminar today. I hope this will be only the first one of many others cooperation that will be conducted, and I hope it will be also for you new experiences maybe as we have so much in common, I mean in the field of practice and also in the field of academic education. So welcome, and I give back to the moderator. Terima kasih.
Thank you, Dr. Astrid, for your forward. So as well, this event is also a collaboration also with Department of Community Medicine, Faculty of Medicine, Universitas Indonesia. And then for the second forward, it's going to be delivered by Head of Department of Community Medicine, Faculty of Medicine, Universitas Indonesia, to Dr. Herkutanto Mars, MPH. The time is yours. Dr. Herku, please, Doc. The time is yours, Doc.
Okay, thank you, Dr. Marsen. Good afternoon, everyone. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you for the introduction, Dr. Marsen, Dr. Astrid, and our distinguished speakers. This is a very extraordinary experience that we have because this afternoon we're going to have a very important webinar called the a multidisciplinary approach of chronic pain among workers. This is a very good example of a collaboration and a multidisciplinary approach between two study programs, the Magister Kedokteran Kerja or Master of Occupational Health, and the Specialist Program of Occupational Medicine, as well as with Department of Physical Rehabilitation from the Faculty of Medicine, University of Indonesia, and Cipto Mangunkusumo Hospital, and then also from a professional organization, Perdoki, Perhimpunan Dokter Okupasi Indonesia. And fully supported by our colleagues from the University Medical Center Groningen, sorry if I say it incorrectly. So I think this is a very important webinar. In this webinar, we're going to discuss several topics regarding chronic pain among workers. We know that in Indonesia, the number of workers from time to time have increased. And along with the increase of the number of workers, there is also an increase in several health problems. One of these is chronic pain. Why chronic pain? Because these workers, the workers in Indonesia, usually work long hours, and perhaps they also have several underlying diseases that may cause a chronic pain. So I would like to welcome our distinguished speaker, Professor Michelle Renneman, Dr. Rita Skippers, and also Dr. Lailana Purvis, our very good friend, because Dr. Lailana have been visiting our department several times. And also Dr. Ibrahim Agung and Dr. Iwan Susilo, our colleagues, Dr. Ibrahim Agung from the Department of Physical Rehabilitation, and Dr. Iwan as an occupational medicine specialist. Thank you very much for fulfilling our invitation and making this collaboration work. I hope this will not be the first and the last, but it will be the first, and then it will continue and grow in the future. Also, I would like to thank the head of the Department of Physical Rehabilitation, Faculty of Medicine, for this collaboration. I hope we can cooperate and collaborate more in the future, and will produce maybe several good research topics, and also several webinars like this. This is of course, this is for the sake of our workers. I would like also to thank the committee that makes it possible, this webinar. I think it's the alumni of the two study programs. So they have worked very hard to make this happen. So to all participants, welcome to the webinars, and I hope you all will enjoy the very fruitful webinars this afternoon. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Herkitanto, for the foreword. And also, I would like to say that this event is not going to be successfully made unless if we are not helped by ILUNI MKK or the Alumni Union of Master of Occupational Medicine, Faculty of Medicine, Universitas Indonesia. And for the next forward, it will come from the head of Department of Physical Medicine and Rehabilitation, Faculty of Medicine, Universitas Indonesia, that will be represented by Dr. Melinda Harini, Physical Medicine and Rehabilitation Specialist. To Dr. Melinda, time is yours, Doc.
Okay, thank you very much, Dr. Marsan. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon to all participants and our colleagues from the University Medical Center Groningen, our colleagues from Occupational Medicine Master Study Program, also from Department of Community Medicine, Faculty of Medicine, University Indonesia. I am very pleased to be speaking to you today on behalf of Physical Medicine and Rehabilitation Department, Cipto Mangunkusumo Hospital, and Faculty of Medicine, University Indonesia. I hope that all of you feel as excited as I am to be part of this great moment. Why do I feel excited? Because actually I'm working in a geriatric division. As you know, in geriatric, we talk much about pain, palliative, dementia, but actually very less about working staff. But anyway, I think there is an important similarity between geriatrics and workers. Both geriatrics and workers are populations that need to get interdisciplinary health intervention. Here, in Faculty of Medicine, University Indonesia, we have integrated geriatric team. It is mainly consists of gerontologists, physiatrists, and psychiatrists. We may be the one and the only one in Asia who have integrated acute geriatric ward. And now, hopefully, in this collaboration between Physical Medicine and Rehabilitation Department and Occupational Medicine Master Study, will be continue and become the dream team in Asia in managing healthy problems among workers. Maintaining collaboration, I believe it is not easy to do. We have to learn each other, grow together, and the most important is facing challenges together. I believe that we have the same optimistic about this. So I think this webinar is a good moment. Let's learn and work together hand in hand, giving better health condition for our workers. So Indonesia will have better productivity. Congratulations for Occupational Medicine Master Program that has initiated this collaborative webinar, One Way Heading to Better Medical Service for Workers. It's been an honor to be in this team. Invitation for our colleagues from University Medical Center Groningen to come and visit our beautiful country and PMR department as soon as pandemic is over. We are so looking forward for the next collaboration. For all participants, please enjoy this extraordinary webinar. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Melinda, for your forward on behalf of Head of Department of Physical Medicine and Rehabilitation, Faculty of Medicine Universitas Indonesia, and Cipto Mangunkusumo National Central Hospital. So before we move on to the next session, we are going to be airing the safety briefing for the event that is going to be a webinar. So I mean, during webinar, to maintain that we are healthy throughout, we are healthy and also we are safe throughout the event. There are some things that needs to be paid attention to, and therefore we are going to be informing to you through this short video. The committee, you can start airing or playing the video for this safety briefing.
Tips sehat dan selamat selama acara daring. PPDS Kedokteran Okupasi FKUI. Selamat datang. Sebelum memulai acara, kami dari Program Pendidikan Dokter Spesialis Kedokteran Okupasi Fakultas Kedokteran Universitas Indonesia akan menyampaikan beberapa tips yang dapat mendukung kesehatan dan keselamatan Anda selama mengikuti acara hari ini. Acara ini dapat diikuti dari rumah atau ruang kerja masing-masing peserta. Pastikan kecukupan kuota data dan lokasi yang menunjang kestabilan sinyal internet, sehingga Anda dapat mengikuti acara hingga selesai. Pastikan Anda merasa nyaman dengan posisi duduk yang ergonomis dan melakukan peregangan secara rutin di sela-sela acara tiap 2 jam. Usahakan setiap 20 menit Anda melihat objek sejauh 6 meter selama 20 detik. Dan aturlah kecerahan dan kontras layar, serta menonaktifkan webcam untuk menghindari keluhan terkait computer vision syndrome. Pastikan pencahayaan dan ventilasi di area Anda mencukupi. Pastikan agar area sekitar Anda bebas dari bahaya. Sebaiknya hindari pengerjaan beberapa pekerjaan secara bersamaan selama mengikuti acara. Perhatikan bahaya listrik dari kabel pengisi daya atau saklar di sekitar Anda. Jangan menggunakan peralatan listrik seperti kabel atau konektor yang rusak. Perhatikan kabel di lantai yang dapat menyebabkan bahaya tersandung. Hindari penggunaan steker dengan koneksi berlebihan. Ketika terjadi bahaya kebakaran selama acara berlangsung, jangan panik. Matikan sumber listrik utama. Padamkan api dengan menggunakan alat pemadam api ringan atau APAR. Bila tidak ada, gunakan kain basah. Bila api semakin meluas, segera tinggalkan area Anda dan hubungi bala bantuan. Bila mengikuti acara ini secara berkelompok, perlu memperhatikan protokol kesehatan COVID-19. termasuk memastikan permukaan benda, meja, dan kursi yang Anda sentuh telah bersih, menjaga jarak, dan menggunakan masker. Terima kasih atas perhatian Anda. Selamat mengikuti acara ini.
Okay, thank you, Reklamati, for playing the safety briefing video. The video was made by students. And before we enter to the next session, I would like to announce that the certificate for this event is going to be distributed after the participants do or perform the post test, the link to which is going to be distributed at the end of this event. So let's move on to the main event for this webinar. It's going to be the first session. The first session is going to be moderated by Dr. Dewi Sumaryani Sumarko, Master of Science, Occupational Medicine Specialist. And on the first session, there will be two speakers. The first one is going to be Dr. Rita, Prof. Michelle Renman. Without further ado, let's move on to the first session. I will hand the event to Dr. Dewi Sumarko. Dr. Dewi, can you hear my voice clearly?
Yeah, okay.
Okay,
yeah,
time is yours, Doc.
Yeah, okay. Thank you, Dr. Marcen. So thank you for the time. So this session, we have two presenters. The first is Dr. Rita, and the other is Professor Reneman. So I will read about the curriculum of Dr. Rita. Dr. Rita supports proper MD, PhD. She is an assistant professor in University of Groningen, University Medical Center Groningen, in Department of Rehabilitation Medicine, Groningen, the Netherlands. She has been graduate from physical therapist, Master Science of Medicines, and then specialist in rehabilitation medicine, and also PhD in rehabilitation medicine. Now she is a chair organizing committee on Pain Congress on October 2021. So, Dr. Rita, please take your time. You have 45 minutes to present your presentation. And then the topic is pain rehabilitation, content and evidence. This is based on your experience. Thank you very much. Please, Dr. Rita.
Thank you very much. I will try to share my screen first to load my presentation. I can load it completely now. Yes, there it is. Is it okay like this?
Yes, you should Control L. You should.
Yes, that's better.
Yes.
I want
thank
to
you very much.
Yes, thank you. I want to thank you very much for a wonderful opportunity to speak in this event and to contact with you in Indonesia. It's very special to me, and I think to all of us. In my presentation, I have no conflicts of interest. This is our rehab center in Groningen. And it's a very nice place to be with a lot of space around. My introduction is a very practical one. It's about daily practice as we work in pain rehabilitation here in Groningen, in the UMCG. And it's a bit of a fundament for the other colleagues from Groningen who will speak after me. It consists of an introduction, very short, a flow chart of how we work, how we diagnose patients with chronic pain, how we treat them, how we assess patients during and after treatment. And when there is time left, I will tell you something about the evidence for the treatments. Chronic pain is also in the Netherlands, as in Indonesia, a big problem. 1 out of 5 adults is confronted with it. It's the most prevalent reason to visit the physician, and it has a strong influence on daily activities, work, and quality of life. Many people with chronic pain have also other problems like depression. They often feel sad, and they have, for example, sleeping problems. They do a big appeal on healthcare, and often there is no simple solution. So people are often very disappointed in us. Costs are mainly caused by loss of work, and in the Netherlands estimated at 20 billion euros a year. So that's a lot of money in a small country. You can see it here. Chronic pain concerns 3 million persons. By the way, we are situated here in Groningen, in the north of the country. Most of the people with chronic pain have chronic low back pain. So my talk will mostly go about chronic low back pain, just to keep it a bit simple also. Chronic low back pain concerns 2.4 million Dutch persons. This is the flow chart of how we work. When there is a patient with chronic pain, he mostly goes to the family doctor at first. And the family doctor can give some therapy in the first line, or refers to a medical specialist to diagnose further for underlying specific causes, or he can refer directly to the rehabilitation specialist. Also, a patient with pain can be seen by the occupational physician, and Michiel will later on tell more about this trajectory. So when the people with pain come to the rehabilitation specialist, they do an assessment of the problems and diagnose the patients as broad as possible. And then they give usually pain education to explain about chronic pain. And then they can follow the next steps. So in many patients, no treatment is necessary. You can just reassure them, give them some advices, and they are okay. Some people need some physiotherapy or psychological treatment in the first line, primary care. Sometimes we refer to another medical specialist because we suspect another underlying cause of pain, for example, a neurologist or orthopedic surgeon. And about 1/4 of these patients we see in the outpatient clinic will be referred for our pain rehabilitation trajectories. Sometimes we give a multi-specialistic treatment together with the pain anesthesiologist, and sometimes with a neurosurgeon who's going to do an operation, and then we treat together after such a treatment. When a patient with low back pain, as the example here, is coming to our outpatient clinic, of course, it is very important to distinguish aspecific from specific pain. Specific, it is only in 5 to 10% of the cases, as you all know. And these patients are very worried when they come to us. They wonder whether they have an arthritis or instability in the back or a degenerative problem or a lumbar herniation or even cancer, etc., etc. So a worried person comes to you, and when you apply the medical model, you do a thorough anamnesis and physical examination as a rehabilitation physician, but also the family doctors do this, of course. Then you could perform to reassure this patient very much because he is worried so much. perform an MRI because you can see everything on it. So you can use it to reassure. And the results of this MRI in this case showed degeneration of 4 lumbar disci, a rupture in the annulus fibrosus L5S1, you can see it there, but there is no root compression at all. Then when you follow purely your medical decision method, your conclusion might be as follows. We have a man here, 52 years old. He has chronic low back pain and he has degeneration of 4 lumbar disci and a rupture in the annulus fibrosus L5S1. There is fortunately no root compression, but he has problems in his job as a builder. The advice of this doctor is it's okay to return to work, but start slowly and avoid bending and lifting, and be better safe than sorry. And this is what is going wrong, because this patient is going to be very fear avoidant, and his future will be low back pain ongoing. We use that, we call that also nocebo effects, which you also certainly know, of course. And you create in a patient negative expectations, and it is so important not to do that. So this doctor is waving goodbye the patients. The patient leaves the room very scary, and we call this a nocebo doctor. And the problem still is, although we know this is not good and it is advised in many guidelines not to do so, it's still happening very, very often. So our country has many, many nocebo doctors. It is important for patients to know that degenerative abnormalities or normalities are very often visible in people without complaints at all. So you can see on this slide, and we always use this also for our patients, that this generation, disc height loss, bulging of discus, protrusion of discus, and also the annular fissure, spondylolisthesis without neurological signs are very often happening in people with no complaints. So there is no direct relationship with these findings and the complaints of the patients. So you see, when we get older, it's all there and very normal, just like our gray hairs, which doesn't hurt either. Also, in the other parts of the bodies, you see these findings. So you always have to be careful and explain to patients that there might be no direct relationship with the complaints. I will save the slides for you, so you can look at it after my presentation also, the next coming days. Also, in advising patients, there are a lot of problems in these nocebo doctors. We are advising patients a lot, and for example, the advice about sick listing to patients. And why do we do it? Well, there are internal factors which are doctor related, and doctors are often fear avoidant, just like the patients themselves. And they have distress because they think that low back pain is very complex, and other chronic pain also. External factors which can influence these advices are patient related. For example, the expectations of the patients which influence the advices of the doctor. When the patient says to the doctor, I think I cannot work at the moment because I am so much in pain, then it will influence the doctor to give the advice to sick list. Also, the findings in clinical examination. When they mention a higher VAS score, the doctor will be more advising sick listing to the patients. External factors, which are employer related, for example, is the attitude of the employer. And for example, he says the return to work is only possible when recovery is complete, or I have no availability of adapted work. All problems that can lead to sick listing low back pain patients, which make it, of course, very difficult also for the occupational physician to go further with these patients and to stimulate them to go back to work. Much better is the biopsychosocial or ICF model for the approach of these patients. The ICF model, I think you all know it also, is that body functions and structure, when there are problems here, they can lead to problems in activity, and they can lead to, on their way, on problems in participation. All is influenced by the health condition of a person, and also, of course, by comorbidity. But also, on the other hand, by contextual factors like personal factors, which can be psychological factors, but also age and background of persons, and environmental factors like the partner of a patient. Maybe the partner is very afraid, or the employer. Why do we use this model? Of course, we have to explore possible specific causes of pain. That always remains important, which need another treatment than rehabilitation treatment, but also to explore underlying predisposing, provocative, and perpetuating factors. It's very important to prevent chronification in the acute stage of pain. So it's very important to use the biopsycho model in the beginning of the complaints, and also when the complaints may be of specific cause, like rheumatoid arthritis or herniation, etc. Also to treat patients optimally with attention for and treatment of these factors, to assess consequences in functioning and participation. So that's also very important, and to prevent relapses after treatment. Here in this slide, you can see the biopsychosocial model in the ICF model. So the red flags are especially here, and the yellow flags for psychological perpetuating factors are here in the personal factors and the environmental factors. Orange flags are about psychiatric problems, which we often see, of course, in chronic pain. Blue flags concern participation and especially work, and black flags concern the law about work and social security. These are the red flags, and they differ between the underlying disease, but also they are different between the different guidelines. So there is no uniformity about red flags. And for us doctors, it's still very important and very difficult also to find the balance between to detect serious underlying diseases, but on the other hand, to prevent unnecessary diagnostic procedures. Personal factors in the assessment can be the mood of the patients, and also the thoughts about his complaints. And there is our role also. Did we already cause iatrogenic damage to the patient? And did we give him already wrong cognitions? Is he fear of movement? Are there life events as perpetuating factors? And what is the coping strategy? Is there avoidance, inactivity? Does the patient function mainly pain contingent? That is mainly a peek-through pattern. It's all very important to assist. Then the environmental factors, the blue flags concerning especially work in this case, is does somebody have a heavy job? Does he have to do a lot of bending and lifting? Does he have to drive a lot? Is there a lot of vibration in the work? But also what is very important is the not matching opinions between the key figures. I don't know whether you recognize that in Indonesia, but it's a very big problem in the Netherlands that everybody has gives his own advice to the patient. And all these advices are different. Advices from the employer, the colleagues, the healthcare giver, etc. And that may have a very negative influence on the patients. Concerning the black flags, that's the availability of work, for example. Is somebody very afraid to lose the job, and the social security? Michiel will tell later on more about that. Well, when we assess the patient, the same patient, according to this model, we get a totally different conclusion with much more tools for a rehabilitation program. The conclusion now is we have a multifactorial specific low back pain in a 52-year-old driven man with an avoidant coping strategy. His cognition is that there might be an underlying discus problem. There are limitations in activities like sitting, standing, walking, and participation in his work and hobbies. And his request for help is to regain workability. What is our approach after this assessment? Well, we get thorough feedback of results of examination, including the results of the X-rays and MRIs, etc. And we always show the pictures also to the patients. We give explanation and reassurance about the findings. Then after that, we talk again about the questions of patients. Are there things unclear? Is he still worried? And then you have to talk it over again and again. Then we give pain education, and we tell about the multifactorial origin of the complaints. And we always take a lot of time for that. It's an extra consultation of about an hour, because it's we think a very good to put energy in this education. We give also websites to the patient with information about chronic pain so that they can look it at home later. If necessary, we give a short period of physiotherapy to reassure the possibility of bending, carrying, and sports. For example, in this patient, always consider a psychologist with the patient, and we follow the stepped and matched care. I will tell that later. First, the pain education. Of course, it will now be a very short form. Otherwise, it will take an hour the way we do it with the patients. We tell about sensitization in our pain education, and we tell about the pain system and how it works and what sensitization is, that our alarm system is going to be too sensible for pain stimuli and no pain stimuli, and that there is influence of different factors on different niveaus in the nerve system. And we show also that you can see on a functional MRI that somebody has pain. So that pain is really visible. And here we have an example of acute pain, and you can see clearly visibility in the limbic system and in the cortex. This one is acute pain, and here we see an example of chronic pain with lower activity, but also still ongoing activity in the brain. And with the trigger points, we try to explain how a patient by themselves can find out whether they are sensitized or not. And their muscles are very sensitive to compression, more sensitive than normal, and they feel it much sooner as pain, and even radiation in the leg can occur. And when they see these slides, they recognize these radiation patterns, and it's very important to reassure them about this. also in the arms or patients with chronic headache, etc. There are many examples of it. Very important to show to patients. Then we are going to look with them at, in a multifactorial way to analyze the problem for every patient specific. And we explain also in this model the roles of the different therapists in the rehabilitation team. So the physiotherapist pays attention to strength, condition, strain in the muscles, etc. Can patient relax, and how does he want to build up his activities? The steps often are far too big to do that. The occupational therapist concerns mainly the daily activities, work, distraction, but also social contacts, household, etc., etc., and how they divide these activities during the day, and the different aspects of all these activities. What you see often in chronic pain is that the focus of the patient is mainly on work. He only can do what he has to do, and after that the energy is finished. The psychologist has attention for mood, for the history with pain, how stressed a patient is by the pain, what effect it has on his relationship, but also on the sleep. There are many sleeping problems in pain patients. So, and still the stepped care approved way to give therapy is very important. Do it simple when it is possible, and do it more complex in interdisciplinary rehabilitation when it is necessary. So you can stop even with explanation and reassurance when this is enough for a patient. You can refer in the case of red flags. In primary care, you can give monotherapy, and we have we are starting to develop networks in the Netherlands with physiotherapists, occupational therapists, and psychologists to work together in also with the primary care. That's new. It's the last couple of years in which we are developing this. And when the problems are very complex and all this doesn't work, you can choose for interdisciplinary rehabilitation. The rehabilitation team consists of physiotherapists, occupational therapists, psychologists, rehabilitation physicians, and when necessary, also the employment consultant can be there. All the team members work according to the biopsychosocial model, and of course they have attention for their own the physiotherapist, for example, for load taking capacity, etc., fear avoidance in moving, psychologists for self-demands, perfectionism, anything that worries the patient, and the occupational therapist about work and daily activities, as I told you before. They work intensively together, all of them, and we have a 2-week team meeting, and there's a lot of cooperation, so we give all the same message to the patients. The treatment goals in our treatment are reduction of fear and depression, to regain balance between load and capacity first, and from there on we go to regain normal daily activities, reduction of medical and paramedical consumption, the reduction of tools and help of others because they only lead to inactivity. Very important in our program is also to go back to work, and self-management in the complaint. So the patient isn't dependent anymore of any doctor or physiotherapist at the end. Pain reduction is not a primary goal, and it's very important to discuss this with the patients before the start of the treatment. The role of the physiatrist during treatment is to give reassurance again when necessary. to give an explanation about the complaints again when necessary. Sometimes we have to confront the patients when they are not doing well and just staying on the same level during treatment and don't make any progress. When necessary, join forces with occupational physicians. And we do that with the telephone or live, but always in presence of the patients. That's a very important one, because then the patient will realize that we all together can work in the same direction. And that reassumption of work is very important for the happiness of the patient. Also, the physiatrist gives a reduction of the use of pain medication as much as possible, a reduction of help of others, and medical consumption. Maybe, yeah, I should ask now if there are any questions to me in the chat, or do we that later on?
I think we can do the Q&A later on.
Because, yeah.
Later on?
Later on, Dr. Rita.
Okay, good, thank you. We do some assessments, and because we are an academic center, we do a lot of assessments. And in the Netherlands, we have the Dutch data set of pain rehabilitation. That's a big questionnaire about the complaints of the patients, the social activities, etc., etc. And we use it as much as possible in all the Dutch centers in the Netherlands, so that we can also in the future can do a lot of research on these data sets. So we are very happy with the implementation of this. And also we do the screening with a lot of psychological questionnaires and functioning questionnaires. Maybe you know them, maybe not, and maybe we can talk about them later. And the psychologists always have some extra questionnaires for patients. At the intake of the team, we do the COPM by the occupational therapist, and the physiotherapist use the modified Astrand bicycle test to tell something about pain behavior and the condition of the patient. We do these questionnaires at the beginning of the treatment, and at the end of the treatment we repeat them, and also after 3 months and 1 year follow up. And at the moment we are also talking about measurements in between during treatment, so that we can assess the patients also during treatment. That may be more important to have more insight in what's happening there anyway. And we share the results of the questionnaires with the patients, and they get a sort of insight in what they scored before and after treatment. This is just a small example, but patients find this very interesting to read about themselves. And I think it's very good help to give them also feedback. I still have some time left to tell you about the evidence of all these treatments. There is evidence of prevention strategies, and this is mainly about low back pain. And there is a publication series in the Lancet in 2018. And I think it's very nice for you also, when you do not know these publications, to look into them. For prevention, we can use the combination of exercise and education in the general population, and also exercise only. You have to move around and not sit the whole day. These are effective, and the evidence for this effectiveness is of moderate or low quality. There's no evidence for back belts or shoe insoles, which are often given still, but there's no evidence for the effectiveness of shoe insoles on low back pain. Also, no evidence yet for ergonomic interventions at the workplace for prevention. There is evidence for ergonomic school furniture in children, but the evidence is of very low quality. The interventions endorsed for non-specific low back pain in evidence-based guidelines is to give the advice to remain active, as well as in acute as chronic low back pain, and also to give pain education. It should be routine care for all of us. Advice to remain active. And what also important is there is clear evidence over and over again that physical activity and exercise in chronic pain, so not only in low back pain, but for all the patients with chronic pain, does not cause harm. So you can use this to explain to your patients, don't be afraid, it's good for you to move, and it's for all these diagnoses applicable. And muscle soreness after physical activity is very normal when you do a new activity. And also very important to know is that bed rest is ineffective. And the evidence is so strong that there is no need for any further studies into this. So never give the advice for bed rest. Interventions for non-specific low back pain, and then especially the pharmacological therapies are only NSAIDs, and then only time contingent, and always in combination with an activating advice. So you can use them in acute and chronic low back pain, but only for a short time, and then give the patient the advice to remain active. Sometimes antidepressants in chronic low back pain, but only in second line or as adjunctive. And opioids are a very big problem, as you all know, for example, in the USA. Use them very limited and only in very selected patients, and with caution, and only for a short time. Other interventions, non-pharmacological, are cognitive behavioral therapy. You could consider it as routine use in chronic low back pain, and limited use in acute low back pain when there are real problems there. The spinal manipulation, massage, acupuncture, yoga, they can all be applied, but always in combination with an activating advice. So the advice to remain active to the patient. So not solely. Mindfulness-based, consider in chronic low back pain, and that is also the case for interdisciplinary rehabilitation. For acute low back pain, we are too expensive. Multidisciplinary biopsychosocial rehabilitation for chronic low back pain, there is evidence for that. The latest Cochrane review was in 2013, and I think they are working at a new one at the moment. But it helps for pain and disability. It has a positive influence on work status, and the effects are of modest magnitude. And also here is mentioned that only those people with indicators of significant biopsychosocial impact are referred to multidisciplinary pain rehabilitation. Some components of our pain rehabilitation are, for example, graded activity and graded exposure, as applied by the physiotherapist and the occupational therapists. And in non-specific low back pain, is graded activity more effective than the control group, but graded exposure is more effective than graded activity for disability. and also more effective for catastrophizing. But maybe you can also use combinations of these. EMDR is very coming up. I don't know how that is in Indonesia, but in the last few years in the Netherlands, it's very much applied. But there is no evidence yet. At this time, the best available evidence for EMDR is case studies and uncontrolled studies, but they are promising. And in our own team, the results are also promising. But there has to be done, of course, some more research on that. The acceptance and commitment therapy for chronic pain is a systematic review in 2017. And there are significant effects, medium to large effect sizes, to pain acceptance and psychological flexibility, and also on measures of functioning, anxiety, and depression. But so far, not significantly effects on pain intensity and quality of life. But it's certainly applicable in the rehabilitation. Psychological therapies for the management of chronic pain, so not only low back pain, is a recent review in Cochrane. They compared CBT, BT, and ACT. And CBT has small beneficial effects for reducing pain, disability, and distress in chronic pain. And BT and ACT still uncertain about the effects. So more research is necessary in there. Then at last, intervention endorsed for low back pain in the Lancet again. And that's only for specific low back pain. We usually don't operate patients with aspecific low back pain. So only a discectomy for herniation with a radiculopathy, but not in the acute phase. Mostly in this phase, we do a watchful waiting, follow the patients, and mostly the problem is solving itself. But when the pain becomes chronic or is very severe, then you can give an operation advice. The same is for spinal stenosis. When the symptoms of the patients fit to the stenosis you see, you can try to operate these patients. Well, in the university here in Groningen, we do a lot of research in our team and also together with the anesthesiologist. It's a very fruitful cooperation in there. And we are working, for example, on the Groningen spine cohort, and that is a cohort of I think, 1,500 patients in there. And we follow them up during 10 years. And we started about 5 years, so we are halfway now, and we do research on them. And it is very interesting to follow these patients. We do also research, for example, in red flags in chronic low back pain. What is the significance of them? How can we use them, etc. The sensitivity, etc., etc. We do also a lot of research in central sensitization and how we can measure central sensitization by questionnaires, by heart rate variability, or quantitative sensitory testing. And we look into relationships between pain, central sensitization, and functional ability on very different ways. It's also very interesting research. We also do research in the relationships between VO2 max and functioning in chronic low back pain, or the PDI and workability in chronic low back pain. And we also did research recently about the therapeutic alliance in pain rehabilitation and the importance of it in the results of our treatments. the influence of physiotherapists' kinesiophobic beliefs on lifting capacity, there are also a lot of nocebo effect here. When the physiotherapist is kinesiophobic, the lifting capacity goes significantly downwards. Also, we do research together with Lailana in the knowledge and attitude of employees and supervisors about low back pain and return to work, because we think there are also a lot of nocebo effects here that employees also might give avoidant strategies to employers when they have low back pain, and that could have a very negative outcome in the end. Also, we did a recent study about long-term effects of rehabilitation. There are a lot of examples more, but I hope we can talk about this together also in the future and do some research, of course, together. I think this is the end of my talk. I want to thank you very much for your attention. It was a lot of information, but you can look afterwards into my slides, and well, we go hopefully in the depth in future of this. Thank you very much, and I wonder whether there are any questions. Maybe you can mention them in the chat.
Yes, okay. Thank you, Dr. Rita. But I think we would like to present Professor Reneman first, and then after that,
Okay.
we got the discussion.
Fine.
Okay?
Yeah.
So the next
I stop
presenter, okay, thank you very much, Dr. Rita. So the next presenter is Professor Dr. Michael Reneman. So he is a full professor rehabilitation medicine in University of Groningen, University Medical Center Groningen, Netherlands. So he graduated of physical therapist, master science in movement scientist, PhD rehabilitation medicine, and also he is co-chair IASP Presidential Task Force Integration ICF and ICD in pain medicine. So Professor Reneman will present the topic integrating healthcare and work and assessment of functional capacity. So please, Professor Reneman, your time is 30 minutes. Thank you. Please unmute Professor Reneman.
Prof. Reneman, you haven't unmuted yourself, so maybe you should unmute yourself first so we can hear your voice. It's the microphone symbol on the left lower side of your screen. You just can put a tap on it.
Yes, now it works.
Yep.
It was a host thing. The host didn't allow me to unmute.
Okay, Prof.
Okay, thank you very much. So you can hear me. Can you also see me for a second or so? And if so, I will share my screen.
Yes, Prof, we can see you.
Okay, great. And I think we are here. Can you see this screen now, this slide?
Yes, Prof.
Yes, Prof, but it's better that
Okay,
full
thank you very
screen.
much. Well, thank you, organizers, and thank you, faculties of occupational and rehabilitation medicine, for this wonderful seminar and this invitation. I was asked to share some of our work, and I'm glad to do that. And I have prepared basically 2 sections of 15 minutes, which are hopefully of interest for you. First, let me disclose any conflicts of interests, and basically it can be summarized as no conflict of interest. Can you see also the my mouse moving on the screen? Dr.
Yes,
David?
Prof.
Excuse me,
Yes.
Prof. It's better
Okay,
that
wonderful.
you
The
set the
slideshow.
full screen for your PPT, the PowerPoint.
It is showing, right? Yeah.
Yeah,
Yeah,
but not
but
in
not the full
slideshow.
screen.
Wonderful.
Slideshow.
And can you see my mouse moving also?
Yes, we can
Excellent.
see.
Perfect.
Yes, okay. Thank you.
Thank you. Anyway, so these are the two sections that I've prepared. First 15 minutes will be about integrating healthcare and work, or basically rehabilitation care and work, and the second on the assessment of functional capacity. And let me right away share this model of rehabilitation, and especially vocational rehabilitation. And it shows the process of an individual towards return to work or disability pension, depending, of course, on the situation of the person. And this runs from sort of what we call medical rehabilitation, and it smoothly goes over from a sort of an interim phase to actually participation at the workplace already. And this is actually the interface where occupational and rehabilitation medicine meet, and that's why my presentation will be about. So there's a medical model. First, of course, there's medical care, then there's medical rehab. And this medical rehab will slowly fade off and will become more non-medical rehab and more work-related rehab. And that is sort of the core of this presentation. And of course, it should lead, hopefully, to return to the labor market. Now, right away, let me start off with a very important evidence slide, and this is a study that was performed by a group of Canadian researchers, and it was published 2 years ago in the Journal of Occupational Rehabilitation, about a systematic review on effectiveness of workplace interventions in return to work for musculoskeletal, pain-related, and mental health conditions. And they are very clear. They are just, there's really no doubt about the evidence for this. There's strong evidence that multi-domain musculoskeletal interventions are beneficial on lost time. So the evidence is strong. And what they're suggesting here is implementing a multi-domain intervention with components in at least 2 of the following domains: health focus, service coordination, or work modification, can help reduce lost time for MSK and pain-related conditions. So that is a strong one right up front. Strong effectiveness that multi-domain interventions are more effective than single domains on absenteeism in this case. And I'm not showing the evidence itself, but please believe me that there's also in this same review evidence that that the cost reduction is also there. However, there is no strong, but there's moderate evidence. So in summary, 3 main components here: healthcare provision, work accommodation, and service coordination. These are the 3 domains that were brought forward, and at least 2 of them, there was evidence that at least 2 of them should be present. However, we do know that rehabilitation programs, not just in the Netherlands, but across the world, they really do differ quite a bit. They differ in content and they differ in dosage, which really makes sense if you understand that every country has its own system, and a system of healthcare insurance, for example, payment systems, but also of social security systems. And that by itself really explains why, at least part of why, rehabilitation programs differ. And that is also why it is so difficult for me as a Dutchman to really read and interpret research from Canada or from Indonesia, and vice versa. If you are reading research from the Netherlands or Canada or the US, you must have to sort of translate that to your own systems to make it work in your own country with your own systems. Now, what we did in our research that I will present really briefly is to test whether each of these three components are essential and they add value. And what we did, we had the research questions: are three components more effective than two components? And the objective of the study was to evaluate return to work and economic effectiveness of vocational rehabilitation with or without an additional work model. And again, it must be very clear that systems are different. And in the Netherlands, there is a mandatory work accommodation. The employer has to apply work accommodations up to 2 years of absence for each employee. And there is a mandatory occupational physician involvement at the first time at 6 weeks of absence. So that may be different from Indonesia, and that's why I'm telling you this. Now, what we studied was what we call VR and VR plus. The plus is the work module, and the VR was a multi-component rehabilitation program consisting of several components that Dr. Rita just presented, and it was quite heavily dosed. We researched programs that had 90 hours of actual therapy time over 15 weeks, and we added an extra 10 hour in the plus version. So the work module is 10 extra hours. The work accommodation in the normal VR was basic, and the other one, there was a work visit that from someone from the rehabilitation team. The service coordination was very basic here, and there was an actual meeting with all the stakeholders in the VR plus version. The cost is approximately €5,000, and the VR plus is the same, but it costs even extra, 1,250 extra, because of these hours, etc. The reimbursement is done here in the Netherlands by the healthcare insurer, and the module is reimbursed by the employer. So this VR program is paid for by the healthcare insurer and the employer. So the work module consists of case management, service coordination, and a workplace visit. That is the plus version. So we had a 2-armed retrospective cohort study. Patients had to have chronic musculoskeletal pain that lasted at least 3 months, but in practice it was way more than that. I think it was an average of 6 or 9 months when they entered the program, and they had to be at least 6 weeks absent from work. We collected the data with questionnaires at baseline, discharge, and 6 months follow-up. And we collected them in usual care in 7 vocational rehabilitation centers along the Netherlands. The selection of the program was not based on what we thought was needed. I think we all agreed all these patients were actually selected for the VR plus, but some employers did not want to pay for that. And then they got the VR program and not the plus program. The return to work outcomes was the clean one, was most important one, was absenteeism. So days away from work. The economic outcomes were calculated from absenteeism, from presenteeism, and quality of life, which was transferred to QALYs. The average age of the participants was very similar. Gender distribution was non-significant. Hours, contract hours were non-significantly different. So was work status. Sick leave was very similar. Oops, I'm sorry. And so was pain disability on a scale from 0 to 10. Sorry, pain intensity on the scale from 0 to 10. The pain disability was slightly lower in the plus group. However, we corrected those for those differences later in the statistics. And so was the return to work expectancy was slightly higher here. And we also corrected for that one. Now the results here on return to work on the vocational rehabilitation and the VR plus, you can basically see that at baseline, most of them are part sick leave and full at work. At sick leave, and at discharge, some were full at work, others were still part-time and full sick leave and 6-month follow-up. And so this is in the absolutely in the direction that we want them to be. And very similar picture here in the plus group, very positive. Both groups very positive. So both in VR and VR plus, we have relevant improvement at discharge and follow-up. VR plus, the differences were small. At discharge, they were non-significant. At 6 months, they were just barely significant, but they were a little bit better on absenteeism only. And then we have the baseline return to work expectations. Those were the only significant predictor for work outcomes. So if a patient basically says is confident that he will benefit from rehab and go back to work, that is a very good predictor for actual outcomes. So this is based on absenteeism only. And now we go to the economic outcomes, which are based on absenteeism, presenteeism, and QALYs, or quality of life scores translated into QALYs. And I will run you through this because this is a cost effectiveness plane. I'm sure you've seen those before, but what it is basically all the observations of the study bootstrapped 1,000 times. And that's when you get this cloud of observations. And the star is actually the average observation, so the point estimate. And the point estimate shows that there's an average, the effectiveness of VR plus is slightly more effective than VR, and everything below this axis means that VR plus is less expensive or economically beneficial. So what we're seeing here is a program that is more effective and less costly. And that is, of course, exactly what we had hoped for, that from a societal perspective, this plus, this extra module of working, bridging between healthcare and work is actually beneficial for not just the patient, but also for society as a whole. And of course, these are the figures, whether it's worth all the money. Yes, it is, at least in the Dutch perspective. Willingness to pay is very, very high. How about the return of investment for the employer? Remember, the employer had to pay 1,250 euros extra. And yes, we have calculated that. And because of a slightly better absenteeism, but a much beneficial presenteeism, the workers are sooner more productive. And that leads to a very positive return on investment for the employer here of 38%. So and that is at discharge even. So we haven't even calculated that for 6 months follow-up. So recapping this, what we already know, so that was the first slide that I showed, that was already known, strong evidence for effectiveness of multi-domain interventions, and there was moderate evidence for cost. We now know that 3 components are more beneficial than 2 components, especially not so much on absenteeism, but very much on presenteeism, on cost for society and cost for the employer. And here again is my provisor, and that is systems matter and a challenge generalization. So we can't say from upfront that this will be the same for you guys in Indonesia. However, the model is supported, the model of healthcare and work modification and service coordination. And of course, you need to tailor this model to fit your system and to make it work in Indonesia. So recapping this back to integrating healthcare and work, what is needed, and Dr. Rita also mentioned it, that it is one goal, one team. And who are the members of that team? Well, of course, the leader here is the patient or worker, but the employer should be involved. So is the rehab team, the occupational physician, and the return to work coordinators, and even others that may be relevant in individual cases or in your system. And it's got to be clear that we have one goal, and that's not either a healthcare problem or a work problem, but we're in the same boat. And if we collect our resources towards that single goal, that will really help for effective and cost-effective care. I would identify the key elements in practice to involve the worker, to involve the patient. That is really directly related to the return to work self-efficacy. That is such a strong predictor for favorable outcomes. Another key one is modified work. Another one is to realize that work or return to work is not just a goal, but also a modality. So you can regard it as a work simulation, and you can have feedback from the patient on what goes right and what goes wrong, and then of course that will interact with you as a rehab team, and you can address any problems or that a patient / worker collides in. So there is the principle of place and train, not just rehab, then go back to work, but integrate these return to work during the rehab program. Only if that's not possible, only then clinic-based work simulations should be considered good, but still second best to real work simulations at the work. Of course, another key element from the healthcare perspective is graded activity and graded exposure, and the biopsychosocial and work orientation of the rehabilitation team. And in some cases, another key element is the return to work coordinator, which could be a dedicated team member with a separate skill set from a typical classic clinician-based skill set. And this person could then take up case management, service coordination, and workplace visits. And the key question, of course, for you guys is to translate this from the evidence and the theoretical models and the Dutch practice that I presented to your Indonesian practice, and maybe later on for the discussion. The question is, would this theoretical model also work for Indonesia? And if the answer is yes, then how would it work? So what is needed for you guys to make it work or make it better work better in your setting? And I think that is the recap of the studies that I presented. And that ends the first 15 minutes. And I think I'm a little late in time, am I not, Dr. Devi?
No, you can continue, Dr.
Okay.
Prof. Veneman.
Okay, and we will have questions later on if I understand correctly.
Yes, after finish your presentation.
Perfect. Then I'll move right on to the second section,
Okay.
which is the assessment of functional capacity. So functional capacity is for especially those of you who are occupational physicians will know this workability house model by Ilmarinen, a very famous model of the Finnish occupational health group. And the functional capacity is regarded as what we call the foundation of the workability house. So functional capacity is something that, if that's a foundation, how can we assess that? Well, in large, there are three means to assess that. That is asking the patient, either structured or standardized with a questionnaire, so self-report, clinician-based, that is, for example, a physician, based on his or her judgment, and what we call performance-based, that is actually performance of functional capacity aspects. And we know from studies that we've even done here in the Netherlands, in Groningen, that these three means will lead to different but related results. If you look at the self-report results that patients in this case with chronic back pain, they self-report their functional capacity, that this will lead to a what we call most disabled status. If you ask them to actually perform what they've just judged in their self-report, it will lead to the least disabled situation. And the clinician, in this case, it was a insurance physician, he or she would judge this person's functional capacity in between. Very important, this one and this one, performance-based and self-report-based, can be done pretty reliably. For those of you, sad news for those of you who are physicians, because the reliability, the inter or intra-rater reliability is often very, very poor. So that is another one that is difficult. So we've done a lot of research in Groningen. Actually, we're one of the market leaders, if you want, for functional capacity evaluation research. We've done a couple of thesis works and many international publications on patients with back pain, on healthy people, osteoarthritis, etc. And now we're also working on functional capacity evaluations for patients with a single arm, for example, with amputees. And we've done a lot of research on safety, reliability, validity issues. And one of the things that we've discovered in a Delphi study is to get consensus to use FCE within ICF. And that leads automatically to the next definition of FCE. A functional capacity evaluation is an evaluation of capacity of activities used to make recommendations for participation in work, while considering the person's body functions and structures, environmental factors and personal factors, and of course the health condition, but that is already known. We also know now that if we use ICF, we can differentiate between capacity and performance, capacity being the highest probable functioning of a person, sort of a lab situation, and performance is what he or she actually does in a specific environment. It is not just a bunch of tests or a machine. For those of you who are somewhat familiar with FCEs, that is still something that people think of this. I would rather call it a form of clinical reasoning built out of 10 components, and one of which is actually testing. And these testings can be very simple, but standardized. And these functional capacity evaluations are batteries of tests. Depending on the protocol that you use, it's 12 or 50 or somewhere in between. It consists typically of lifting and carrying capacity, postural tolerance tests, repetitive work tests, hand function tests, and also some aerobic capacity tests, which are not here yet. So if you do all these tests, it takes multiple hours. That is really not needed. You can do one or a few tests, and that is really done, could be done in a few minutes. They come in all different shapes and forms. And it's good to differentiate between what I call a functional capacity and a work capacity evaluation. A functional capacity is standardized, more lab-based thing, and a work capacity evaluation is very much tailored to work, so it's less abstract and more concrete and closer to the actual work. And there's good examples, at least here in the Netherlands, but I'm pretty sure also in Indonesia, for firefighters with their periodic screens with functional testing, and so are the police force members. So these protocols can differ between very generic and specific, short and long, even 2 days, 1 hour, or 15 minutes, up to 4 hours, technology-based, clinical-centered. Whatever your choice is, you would probably have to be rational about that. And out of this package of 20 tests, you can take your choice that based on the referral question, the diagnosis, or the work situation. And you can report it somewhere between very short and very long. The reference of your capacity testing is actually the workload. So if this guy can do 10 kilograms at work, at the lab, and he has to work at work, lift, for example, 20 kilograms, then there's a problem. If he can do 30 kilograms and at work max 20, then he's okay for that. That is the simplest form of comparing capacity and workload. And of course, it's not just lifting, but it's also overhead working, etc., etc., etc. All right. And here's another example of a firefighter's very specific firefighting protocol that is being done, well, basically all over the world. Also in Groningen, that's where I did one of these tests and I passed, just for your information. But that was for me very good to get a grip on, in this case, to learn the ins and outs of the test for firefighters. Scientific developments have of the last 20 years have been great. So what we can say now about this, I think it's about 100 studies altogether taken in one slide. We can measure it safely and reliably. We are getting a better understanding of the validity, and we can use it to better predict work status. We also know that we can do very short protocols without losing quality, because we know that one or few tests are predictive basically of all these 20 other tests. So that is very good from the economic perspective or efficiency perspective. We have relevant references, criterion references based on the workload. But we also know that the individual variation between tests is very substantial and still not very much explained. What we have learned that functional capacity outcomes are not limited to physical factors only. So it's not just strength, coordination, and endurance, but it's also fear, depression, etc., etc. And there's this individual interaction between bio, psycho, and social factors that really get into these results. And as a clinician, it is your work to sort of disentangle this underlying issues. So here's the summary of a systematic review that we did. Strong evidence that a number of performance-based measures are predictive of work participation. It's just a small addition, of course, and that's pretty clear if you realize that the construct of workability is multidimensional, and it's really not. It should not be regarded as the same as return to work, because there's a lot more going in, and this is just one of the components. So summing it up, self-report, clinician-based, performance-based, all three measures have their positives and negatives. All three should be used, in my opinion, for a comprehensive assessment of functional capacity. And if you're interested, you can either buy a commercial protocol, and there's many of them that you can buy. Some of them are pretty expensive, other ones are better priced. And if you are interested, I too, it sounds like a sales pitch, but I do give evidence-based FCE courses. And if you're interested, please let me know. So that sums it up. I thank you for your attention. And I think, Dr. Devi, we will go down now back to a question session, right? With Dr. Rita.
Yes, thank you very much, Prof. Renemar. So this is a very interesting presentation for you. Okay. The committee, is there any question for Dr. Rita first? I think you have some questions.
Maybe Prof. Renemar can stop sharing the
Okay.
slides first, Doc.
Prof. Renemar, could you please stop share screen?
I am sorry.
Thank you.
Oh.
Yes, okay. I think there is several questions for Dr. Rita. Yeah. Okay, Dr. Rita, there is a question from Dr. Marsen. The question is, sometimes pain reduction is the only thing that patient wishes in the case of chronic pain. How do we match or the patient's expectation if in psychologically speaking, the pain will not subside? Okay,
Yeah.
that's the first question for you.
We explain to patients that pain reduction is in the rehabilitation treatment not a primary goal, but research shows that pain reduction is happening with rehabilitation treatments, also significant results on that. But it's important to discuss about that with the patients, that we don't primarily aim at pain reduction, but by changing the way of functioning, changing the way they do things, and to regain activity is going to lead to the fact that the pain is more going to the background and more more or less in the front of the brain, something like that. They learn to adjust and to accept pain, and when they do, and the situation is getting more balanced, then the pain reduction is coming. It's not much, but it is coming.
Okay.
But some people are still disappointed at the end of treatment. They keep hoping of reduction on reduction of pain. But you have to stay talking about it, and of course it is very important also to accept pain. The resistance to pain keeps an ongoing sensitization process. It remains.
Thank you, Doc.
Yeah.
Yeah, okay, thank you, Dr. Rita. And then another question from Dr. David. Dr. David, is there a questionnaire or tools that can accurately calculate the percentage of disability due to chronic pain? In the AMA guidelines, the pain disability questionnaire is often used. Can it be used in all situations?
Well, we use it in all situations, but it's not the best, and we are still trying to find better ways. It's also important to give proof to the efficacy of our treatment, and the pain disability questionnaire doesn't measure everything we want to measure. We did also research in that, and we asked patients. It was a qualitative research, and the conclusion was that the questionnaires don't measure what patients find really important. So we are looking into that, and we mainly also by qualitative studies and asking patients what is important for them. And the pain disability index is used worldwide, but we still think it's not the best. But we have to try to find better. Michiel, maybe you have
Yeah.
also
Comment?
No,
Prof.
well,
Renneman?
yes, what I would like to add to that is especially for disability assessment within the American Medical Association guideline. Well, one thing, the AMA are based on body functions and structures, and not so much on functional capacity, so not much on the activity or on the participation level. And if you would like to assess that questionnaire-based, which is self-report, please make sure that you're measuring self-reported disability, which may not be the same as what a person can actually do. And not that one is better than the other. You just have to just have to realize that it is not the whole truth, neither one of them.
Yeah. Okay. So, Dr. David, are you satisfied? Okay. Another questions? This is another questions from Dr. Agustina Puspitasari. Would you please sharing to us one example how biopsychosocial team treat patient that his job must do manual handling with chronic pain that caused by this lumbar degeneration until the patient return to work? Could you please share?
Yes.
Okay,
What we do is first do the assessment. What are the problems also concerning work? And then we try to reactivate the patient to go into work. We do that during the treatment already in the about the fifth week. And then we get a connection with work with the occupational physician. We mostly do that via the patient himself. But when it is unclear, then we have this meeting with the occupational physician and the patient and the physiatrist to make a plan for the patient. And then he has to just with small steps regain his work activities. And usually we don't give any limitations in work, but just to build up gradually and looking at what is going wrong in building up activities and where can you make corrections so that it goes better. But no restrictions in this case. Michiel.
Yeah, if I may add to that, there's a very important question underlying this question, and that is whether this back pain is actually caused by lumbar degeneration. And I think, and Dr. Rita really explained that very well, that in the beginning, at the very front of the rehabilitation program, there's this educational part, of course, first the medical assessment and then the educational part, that to sort of get the patient's cognition in the right way, that this lumbar degeneration may very well be just aging, and it may not have a direct relationship with the back pain. So that deconnection is something that the physician is really important part of.
Okay, thank you
The
very
gray
much.
hair thing.
Yeah.
Yeah, thank you very much for Professor Renneman. I think, yes, another, okay, thank you very much. That's all for the questions to Dr. Rita. And this is the question for Professor Renneman. The question is, kindly provide us your opinion regarding low-level laser. Oh, this is the comment for your presentation. Kindly provide us your opinion regarding low-level laser treatment for muscular chronic pain treatment. So it means that suggestion that if you can give us your opinion.
I can do that, of course, but I think this is part of the evidence table that Dr. Rita shared with us. But I can, if okay with you, Rita, low-level laser treatment. I from my top of my head, the level of evidence is very low, and if it is, it should be seen probably as a symptomatic, but not something a lasting effect. So I would say not an active thing. So stay away.
Yes, and at least combine it with other activating treatments.
Yes. Okay. Thank you, Prof. Renneman and also Dr. Rita. And then another question from Dr. Marsen to Prof. Renneman. Regarding to the ultra short protocols, is there any guidance for which movements is needed to test for certain types of occupation?
Yes, there is. There's a few papers. If you're interested, I can either go into that in a later sit. But the two lifting tests are really on top of the list for the relevance of choice. So a lifting low and a lifting high. So an elevated lifting test. Those two. Basically, I think from the top of my head, about 90% of the variance of the full protocol, with only two tests. And there's lots and lots of evidence on the validity and the reliability on these two tests.
Thank you, Prof, for the answer.
Thank you. And then another question, I think. Okay, from Dr. Fransen. Another question, I think, from Dr. Marwan. Should work capacity be measured ideally on regular basis or only when the worker has health problems? Prof. Renneman?
That is a good question. That's a very interesting question. I know for example, within the police or in the firefighting world in the Netherlands, there's what we call a periodic screen, where every year they have to do these functional tests. And if they don't have, if you don't meet the requirements, you're not allowed to go on active duty. Whether it should be done, probably yes, but then it is indeed and the guidelines are pretty clear about that. There must be a good reason for doing so, and in the police and in the firefighting departments, I think there is a good reason. And if you do testing regularly, they should have a direct connection with the work, and so you cannot just do for example, a blood pressure test every year or so, because that has no connection with functional capacity or work capacity. But these functional tests, like I showed, for example, for the firefighters, they should ideally be measured on a regular basis, indeed, to prevent, hopefully, loss of work capacity. And of course, there's this natural aging thing. So if you're 60 years old, you're probably not as strong, and your aerobic capacity is later than the same person would have been when he was 20 or 25 years old. Now, if the work capacity is still at the same level, then there may be along the line some decline in functional capacity. And of course, if you have a health problem, then this decline may go a little faster than normal aging.
Okay, thank you, Prof. Renneman. So I think the committee has give a sign to me. The time is up. Okay, so I'm very thank you for Dr. Rita and also Prof. Renneman presentation. It's very interesting, and it's very, we call it about a good information, and I think a new information for us about how to we treatment or we do the pain rehabilitation, and also how do we do the collaboration and assessment of functional capacity. So okay, thank you very much for all the presenter. And then so the times is up, and I give to the master ceremony to Dr. Marsen again. Thank you very much for your
Thank you.
time and your beautiful presentation. Thank you.
Thank you.
Thank you.
Sorry. Thank you, Dr. Dewi, Prof. Rendeman, and also Dr. Rita for the very, very informative material that you have provided us. So for the next 20 minutes, we are going to have a little break for stretching, and also maybe some of you want to do the afternoon prayer, the Astar prayer, then we can do by this time. And we will start the second session in 3:45 or 15 minutes to 4 p.m. So I'm going to give the session to the other committee to maybe they have some videos to be playing to you. Thank you, and see you at 3:45. Thank you.
Program Pendidikan Dokter Spesialis Kedokteran Okupasi diselenggarakan oleh FKUI dan pertama di Indonesia sejak tahun 2006, serta telah meluluskan lebih dari 150 dokter spesialis kedokteran okupasi. Di bawah Departemen Ilmu Kedokteran Komunitas Divisi Kedokteran Okupasi, prodi ini memiliki visi menjadi prodi yang terkemuka dan menghasilkan lulusan dengan kompetensi yang diakui pada tingkat nasional maupun internasional. FKUI bekerjasama dengan Kemenakertrans, Kementerian Kesehatan, Rumah Sakit Pendidikan, dan industri terkait. Staf pengajar berasal dari berbagai disiplin ilmu, baik spesialis maupun profesional lain sesuai bidangnya.
Assalamualaikum warahmatullahi wabarakatuh. Salam sehat untuk semua. Program spesialis kedokteran okupasi adalah program pertama dan satu-satunya khususkan pada penanganan kesehatan pekerja. Prodi kami menekankan pada penanganan yang holistik dan komprehensif terkait dengan upaya surveillance kesehatan bagi pekerja, diagnosis penyakit akibat kerja, penentuan kelaikan kerja, program kembali bekerja, dan perhitungan kecacatan. Melalui kegiatan Tridharma Perguruan Tinggi, kami bekerja sama dengan rumah sakit pendidikan terkait dengan industri. Kami juga bekerja sama dengan perusahaan serta mengembangkan penelitian di bidang kesehatan kerja. Kami membekali peserta didik kami dengan kegiatan pengabdian masyarakat. Tentunya hal ini akan membuat lulusan kami sebagai lulusan yang kompeten untuk melaksanakan pelayanan kedokteran okupasi baik di rumah sakit maupun di perusahaan.
Tridharma Perguruan Tinggi adalah salah satu visi dari seluruh perguruan tinggi yang ada di Indonesia. Tridharma Perguruan Tinggi terdiri dari 3 poin, yaitu pendidikan dan pengajaran, penelitian dan pengembangan, pengabdian kepada masyarakat. Maka dari itu, program pendidikan dokter spesialis kedokteran okupasi FKUI yang berlangsung selama 3 tahun atau 6 semester mengaplikasikan poin-poin tersebut selama kegiatan pendidikan. Kegiatan pendidikan berlangsung dalam 3 tahap, yaitu tahap Selain kegiatan belajar mengajar, terdapat beberapa kegiatan ekstrakurikuler rutin yang dilakukan oleh PPDS Kedokteran Okupasi, yaitu Okurunners, Biko, berbagi ilmu kompetensi okupasi. Biko adalah media pembelajaran jarak jauh bagi PPDS Kedokteran Okupasi untuk dapat mempelajari lebih dalam mengenai kompetensi-kompetensi yang harus dimiliki oleh dokter spesialis kedokteran okupasi. Pelatihan, seminar, IOMU, Indonesian Occupational Medicine Updates. Selain itu, juga terselenggara secara rutin setiap tahunnya kegiatan ilmiah Indonesian Occupational Medicine Updates atau IOMU yang menjadi pembelajaran yang baik bagi mahasiswa PPDS Kedokteran Okupasi.
Menjadi peserta PPDS Kedokteran Okupasi adalah kebanggaan bagi saya, karena banyak ilmu yang bisa dipelajari dan diterapkan di tempat kerja.
Kedokteran okupasi memainkan peranan yang sangat penting dalam bidang oil dan gas industri. Karena pada bidang ini banyak terdapat hazard dan risiko yang penanggulangannya hanya bisa dilakukan dengan pendekatan kedokteran okupasi.
Saya mahasiswa tugas belajar dari pemerintah Kota Pekanbaru untuk memenuhi kebutuhan SDM akan spesialis kedokteran okupasi.
Di sini Anda akan berjumpa dengan staf pengajar yang baik, berpengalaman, yang akan membagikan semua hal yang aplikatif di tempat kerja Anda nanti.
Saya bangga menjadi bagian spesialis kedokteran okupasi FKUI dan memberikan layanan kesehatan. Terima kasih.
Sebagai lulusan program studi kedokteran spesialis okupasi FKUI, saya merasa ilmu saya dapat sangat bermanfaat dalam kinerja saya sebagai officer PGN Saka. Health surveillance dan penentuan fitness status menjadi utama kami dalam mendukung operasional perusahaan. Bravo PPDS Okupasi FKUI.
Sebagai perusahaan yang berkomitmen untuk menjalankan sistem kesehatan kerja yang lebih baik dari yang diminta oleh peraturan, Komatsu Indonesia sangat beruntung bisa kerjasama dengan program pendidikan dokter spesialis kedokteran okupasi Fakultas Kedokteran Universitas Indonesia.
Assalamualaikum warahmatullahi wabarakatuh. Saat ini sudah menjadi kebutuhan rumah sakit untuk menyiapkan layanan kedokteran okupasi, terutama bagi rumah sakit yang melayani perusahaan. Hal ini diperlukan untuk mendukung kebutuhan operasional perusahaan dalam hal penyiapan sumber daya manusia yang sehat dan siap untuk mendukung produktivitas perusahaan.
Selamat datang di program studi Magister Kedokteran Kerja Fakultas Kedokteran Universitas Indonesia, yang merupakan program studi yang mendidik para dokter yang berkeinginan untuk memperdalam ilmu di bidang kedokteran kerja dan kesehatan kerja. Berikut ini adalah visi dan misi dari program studi Magister Kedokteran Kerja.
Program studi Magister Kedokteran Kerja adalah suatu program studi yang mahasiswanya dokter semuanya, yang ingin memperdalam ilmu kedokteran kerja dan kesehatan kerja. Program studi ini didirikan pada tahun 1978 dan saat ini merupakan satu-satunya di Indonesia serta di Asia Tenggara.
Program studi kami telah meluluskan lebih dari 600 dokter bergelar Magister Kedokteran Kerja. Telah bekerja di berbagai sektor, minyak dan gas, manufaktur, pendidikan, rumah sakit, dan juga TNI dan Polri. Alumni kami telah tersebar ke berbagai Nusantara, dari Aceh sampai Papua, bahkan ke mancanegara.
Sebelum terjadi pandemi, program studi Magister Kedokteran Kerja selain menerapkan pembelajaran tatap muka di Pegangsaan Timur, Laboratorium Hiperkes dan Keselamatan Kerja, serta lokasi lainnya, juga merintis pembelajaran jarak jauh dan telah diuji cobakan untuk beberapa mata ajaran unggulan khas Magister Kedokteran Kerja. Setelah terjadi pandemi pada awal bulan Maret 2020, semua kegiatan pembelajaran dilaksanakan secara daring menggunakan fasilitas Zoom Meeting, Google Classroom, dan lain sebagainya. Program studi Magister Kedokteran Kerja melakukan penelitian di berbagai provinsi di Indonesia dan internasional, serta berbagai sektor seperti industri, pertanian, pertambangan, migas, perkantoran, sektor informal, dan seluruh penelitian telah lolos kaji etik dari Komite Etik Penelitian Kesehatan FKUI dan dilakukan pemaparan hasil di hadapan staf pengajar, mahasiswa, dan alumni. Staf pengajar, alumni, dan mahasiswa menjadi pembicara di berbagai seminar atau webinar yang diadakan oleh program studi, organisasi profesi, fakultas kedokteran, dan universitas, serta berbagai instansi baik negeri maupun swasta, dan juga melakukan kegiatan kemanusiaan dan turut membantu pemerintah dalam pencapaian program kesehatan kerja. Program studi Magister Kedokteran Kerja memiliki komunitas lari dengan nama MKK Runner yang diikuti oleh staf pengajar, alumni, dan mahasiswa dengan tujuan menjaga kesehatan dan kebugaran tubuh.
Program studi Magister Kedokteran Kerja Fakultas Kedokteran Universitas Indonesia dapat mengakomodir kebutuhan industri akan kedokteran kerja, kedokteran kelautan, dan bahkan kedokteran penerbangan.
Dan Prodi MKK FKUI memiliki staf pengajar dari berbagai disiplin ilmu dan tempat praktek mahasiswa di berbagai tempat kerja dan perusahaan,
sehingga memberikan kesempatan kepada kami untuk siap ditempatkan di berbagai sektor.
Sebagai dokter perusahaan, ilmu manajemen kedokteran kerja sangat bermanfaat bagi saya pribadi.
Dalam upaya meningkatkan kesehatan kerja bagi pegawai.
Saya bangga menjadi bagian keluarga besar Magister Kedokteran Kerja Fakultas Kedokteran Universitas Indonesia.
Jadi kami sangat terbantu, sangat merasakan peran profesional yang dilakukan oleh lulusan kesehatan kerja yang ada di tempat kami. Secara khusus, saya mengucapkan banyak terima kasih kepada program studi Magister Kedokteran Kerja FKUI atas lulusan-lulusan yang dihasilkan yang sangat kompeten dan nyata dalam melakukan tugas-tugasnya.
Terima kasih FKUI atas kelulusannya dan tetap selalu memberikan kepada kelulusan yang terbaik.
Program Pendidikan Dokter Spesialis Kedokteran Okupasi diselenggarakan oleh FKUI dan pertama di Indonesia sejak tahun 2006, serta telah meluluskan lebih dari 150 dokter spesialis kedokteran okupasi. Di bawah Departemen Ilmu Kedokteran Komunitas Divisi Kedokteran Okupasi, prodi ini memiliki visi menjadi prodi yang terkemuka dan menghasilkan lulusan dengan kompetensi yang diakui pada tingkat nasional maupun internasional. FKUI bekerjasama dengan Kemenakertrans, Kementerian Kesehatan, Rumah Sakit Pendidikan, dan industri terkait. Staf pengajar berasal dari berbagai disiplin ilmu, baik spesialis maupun profesional lain sesuai bidangnya.
Assalamualaikum warahmatullahi wabarakatuh. Salam sehat untuk semua. Program spesialis kedokteran okupasi adalah program pertama dan satu-satunya yang mengkhususkan pada penanganan kesehatan pekerja. Prodi kami menekankan pada penanganan yang holistik dan komprehensif terkait dengan upaya surveillance kesehatan bagi pekerja, diagnosis penyakit akibat kerja, penentuan kelaikan kerja, program kembali bekerja, dan perhitungan kecacatan. Melalui kegiatan Tridharma Perguruan Tinggi, kami bekerja sama dengan rumah sakit pendidikan terkait dengan industri. Kami juga bekerja sama dengan perusahaan serta mengembangkan penelitian di bidang kesehatan kerja. Dan kami membekali peserta didik kami dengan kegiatan pengabdian masyarakat. Tentunya hal ini akan membuat lulusan kami sebagai lulusan yang kompeten untuk melaksanakan pelayanan kedokteran okupasi baik di rumah sakit maupun di perusahaan.
Tridharma Perguruan Tinggi adalah salah satu visi dari seluruh perguruan tinggi yang ada di Indonesia. Tridharma Perguruan Tinggi terdiri dari 3 poin, yaitu pendidikan dan pengajaran, penelitian dan pengembangan, pengabdian kepada masyarakat. Maka dari itu, program pendidikan dokter spesialis kedokteran okupasi FKUI yang berlangsung selama 3 tahun atau 6 semester mengaplikasikan poin tersebut selama kegiatan pendidikan. Kegiatan pendidikan berlangsung dalam 3 tahap, yaitu tahap dasar, tahap magang, dan tahap mandiri, serta dikemas dengan sangat menarik sehingga mahasiswa mendapatkan pengalaman dalam berbagai kegiatan belajar mengajar. Selain kegiatan belajar mengajar, terdapat beberapa kegiatan ekstrakurikuler rutin yang dilakukan oleh PPDS Kedokteran Okupasi, yaitu Okurunners, Biko, berbagi ilmu kompetensi okupasi. Biko adalah media pembelajaran jarak jauh bagi PPDS Kedokteran Okupasi untuk dapat mempelajari lebih dalam mengenai kompetensi-kompetensi yang harus dimiliki oleh dokter spesialis kedokteran okupasi. Pelatihan, seminar, IOMU Indonesian Occupational Medicine Updates. Selain itu, juga terselenggara secara rutin setiap tahunnya kegiatan ilmiah Indonesian Occupational Medicine Updates atau IOMU yang menjadi pembelajaran yang baik bagi mahasiswa PPDS Kedokteran Okupasi.
Menjadi peserta PPDS Kedokteran Okupasi adalah kebanggaan bagi saya, karena banyak ilmu yang bisa dipelajari dan diterapkan di tempat kerja.
Kedokteran okupasi memainkan peranan yang sangat penting dalam bidang oil dan gas industri. Karena pada bidang ini banyak terdapat hazard dan risiko yang penanggulangannya hanya bisa dilakukan dengan pendekatan kedokteran okupasi.
Saya mahasiswa tugas belajar dari pemerintah Kota Pekanbaru untuk memenuhi kebutuhan SDM akan spesialis kedokteran okupasi.
Di sini, Anda akan berjumpa dengan staf pengajar yang baik, berpengalaman, yang akan membagikan semua hal yang aplikatif di tempat kerja Anda nanti.
Saya bangga menjadi bagian dari spesialis kedokteran okupasi FKUI dan memberikan layanan kesehatan kerja untuk negeri ini. Terima kasih.
Sebagai lulusan program studi kedokteran spesialis okupasi FKUI, saya merasa keilmuan yang saya dapat sangat bermanfaat dalam mendukung kinerja saya sebagai Chief Medical Officer PGN SAKA. Health surveillance dan penentuan fitness status menjadi menu utama kami dalam mendukung operasional perusahaan. Bravo PPDS, Okupasi FKUI.
Sebagai perusahaan yang berkomitmen untuk menjalankan sistem manajemen kesehatan kerja yang lebih baik dari yang diminta oleh peraturan.
Thank you, the committee, for playing the video profile for the study program. So welcome back to the event. We are going to continue with this second session. In this second session, the session will be moderated by Dr. Arya Kekali, MTI. And there will be 3 speakers for this session. The first speaker would be Dr. Ibrahim Agung, a specialist for physical medicine and rehabilitation. And the second speaker would be Dr. Lailana Purvis from the UMCH. And then the last speaker would be Dr. Iwan Susilo Joko, which will be talking about the occupational aspect of chronic pain management in workers. So for the second session, I will be giving the time to Dr. Arya. Dr. Arya, are you there? Dr. Arya. Okay, so before Dr. Arya is here, I would like also to remind to all of you that the certificate for this event will only be distributed after you completed the post-test, and the link to the post-test will be posted, I think, at the end of this webinar. And the link to the post-test will only be open until April 18, which is tomorrow, by 12 p.m. Western Indonesian time. So after 12 p.m. Western Indonesian time, the link will be closed and it will no longer accept responses. And we'll only be distributing the certificate based on those who have answered the post-test. So Dr. Arya is already here? Dr.
Yes.
Arya? Okay. Dr. Arya, I will give the time to you. Please, the time is yours.
Thank you, Dr. Marcin. So we come to the second session of our webinar today. So in this opportunity, I will introduce the first speaker for the second session. Our speaker will be Dr. Ibrahim Agung, specialist of the physical medicine and rehabilitation. So he is a staff in the physical medicine and rehabilitation specialist, a neuromusculoskeletal expert. He is graduated from the physical medicine and rehabilitation specialty in 2017, and he went into some international fellowship in the Taiwan and also in the China in 2017 and 2019. So he will present about the physical medicine and rehabilitation collaboration in chronic pain management among Indonesian workers. And I believe Dr. Agung is ready now. So please, Dr. Agung, time is yours, 20 minutes.
Thank you, Dr. Arya. Can you hear my voice very clear?
Loud and clear, doctor.
Okay, so I will share my presentation first, yeah? Can I have an access to share the screen?
For sure. Sorry. Okay, please go on, Dr. Agung.
Is it my presentation? Can be seen clearly?
Very clear.
Okay. Thank you very much, Dr. Arya, as a moderator, and also thank you for the committee to invite me in this wonderful event. Assalamualaikum warahmatullahi wabarakatuh. So today I'm Dr. Ibrahim from Physical Medicine and Rehabilitation Department from Cipto Mangunkusumo Hospital, Faculty Medicine of University of Indonesia. Today I will share experiences about the physical medicine and rehabilitation collaboration in chronic pain management among the Indonesian workers. So I will start my presentation with a case report. This is a real case report. Male, 26 years old, as a rescuer, or in Bahasa, he works as in Basarnas. He came to our clinic with the chief complaint of pain on the lower back during working. If we see from the visual analog scale or pain numerating scale, the pain is like 5 until 6. He felt pain since 1 year ago, actually, especially during trunk bending and lifting weight. And actually, there's no like radiating pain or weakness or numbness or tingling sensation. And his pain has reduced after he changed his position or resting. So during working, he feel pain, but after resting, he felt that the pain is gone. From physical examination, we found that he has the hypolordotic posture while we're doing or assess the posture, and also a lot of spasm on the erector spine muscle, including the spinal muscles, the longissimus, the iliocostalis, and also the quadratus lumborum muscles. We also did the spatial tests, a lot of spatial tests, but all of the spatial tests showed that the negative result. We did the MRI imaging, and we found that he has the bulging disc on L3, L4, L5, S1 without the compression into the tackle sex, But on the L5, he has a disc protrusion with indentation into the left radix and slightly compression on the tackle sex. So based on these cases, we diagnose patient with the low back pain due to the disc protrusion and differential diagnosis with the erector spine muscle spasm. And we do plan for this patient with the low-level laser therapy. So this is the doctor or we as a specialist that do this treatment, especially on the root of the spinal cord in L4, L5, and also the erector spine muscle group. We also ask to our team, which is the physical therapist, to give him the diathermy and also massage, manipulation, stretching, and also the home exercises. And we also give him with the lumbosacral orthosis corset to at least support the spine and reduce the pain. So based on this case report, this is a very classic problem, which is the low back pain. And also this is a very classic diagnosis also planned for a patient, even he is a worker, for treating the patient with the chronic pain. From this case report, we can see that actually this is a very classical model of a treatment. When the physician, in this case, a PMR specialist, become the center of the treatment. But actually, this is in the past. Even in our team, in physical rehabilitation department, we have a lot of team. We have like the physiotherapy or physical therapies. We have also the occupational therapists. We also have the special nurse. We have the psycholog. We also have like the speech therapies, orthotic, prosthetic, and all of big team. So for many cases of the chronic pain, actually we treat many treatment with to the patient. Basically, we can divide into two kind of medication or treatment. The first one is medication. We give a lot of like the anti-inflammatory medication, painkiller, muscle relaxant, nerve protector or neuroprotector, and also non-pharmacological interventions such as like immobilization technique, positioning, and also the therapeutic modalities, manipulation, mobilization, and also the exercises, because we believe that with the exercises, not only we treat the pain, but also the prevention for the future to reduce the recurrence of the chronic pain. And also the orthosis, because some orthosis is very important to help and support the patient for doing their works, their activity, and also prevent the re-injury for the future. We also did a taping, walking aid, and also many technique like relaxation, also music therapy. So we went to the therapeutic modalities. Actually, there's a lot of therapeutic modalities. I think Dr. Rita already mentioned all of the evidence regarding of the therapeutic modalities. So in our department, we use the laser. I think one of member already asked about the low-level laser therapy. Yes, this is the laser. We use the low-level laser therapy for some kind of pain or some kind of diagnosis. We can treat a patient with the low-level laser therapy. But yeah, the indication is supposed to be very specific, or it means that not all of the chronic pain can be treated with one treatment or one modality. Laser also very good for reducing the pain, reduce the inflammation, and also stimulate the healing process actually. But for regenerative, we also have DR machine like the shockwave therapy, like this one, either the extracorporeal or the radial shockwave therapy. So for many tendon problem, for example, like this, we have many rotator cuff injury like the supraspinatus tendinosis, and also DR tendinosis or epicondylitis, plantar fasciitis that also related to working. We can treat very good without invasive treatment, but with modalities. We also treat the patient with electrical stimulation, but basically it's blocked with the gate control mechanism to block the pain that come to the brain or the central nervous system with the electrical stimulation. We also reduce the muscle spasm with the diathermy. There's a big diathermy, we call the shock wave, and also the microwave diathermy, and also the small one with the ultrasound diathermy. And last, we give a patient sometimes in the low back pain with the traction. Even it is very classic, but yeah, in the fact we still use it for treating the chronic pain in our clinic. Besides therapeutic modalities, but basically there are four functions of the agent that we give. The first one, the modalities can stimulate the larger diameter of afferent fiber. The second, it will decrease the pain fiber transmission velocity. So the modalities like the cold or the ultrasound diathermy, it will reduce the velocity. The third, it can also stimulate the small diameter afferent fibers, for example, like the A delta or C fiber and descending pain control mechanism. So even we only give a pressure to the muscle that is become the myofascia, like Dr. Rita already explained, myofascia. Actually, it's also help the patient to reduce the pain. And finally, we can start to continue with the other treatment. And the last, also stimulate a release of beta endorphin, because many modalities will induce the endorphin and increase the endorphin level. So when the patient's endorphin level is getting higher, then the pain will also reduce. Besides modalities, we also give the exercises. Basically, we give any kind of exercises, but we start with the range of motion exercises. The second is the flexibility. After range of motion is getting full, and we going with the flexibility. After the flexibility is getting better, then we start to do the strengthening exercises related to the structure that become a problem. So for example, if you have or the patient have the knee osteoarthritis, then we will strengthen the quadriceps and also the hamstring muscle. If they have the low back pain, of course, we need to increase or strengthen the core muscle that will support the spine and also the disc that usually become a problem. We also give a specific exercise like aerobic exercise, because sometimes not only pain, or pain is not only giving a pain symptoms, but pain also will give reducing the endurance of the patient while they are doing the exercise or doing their work. We also give the orthosis. We have our own workshop that will make a custom made like a brace, like a corset or many kind of splint in our workshop. So for treating a patient with chronic pain, yeah, all of this treatment we will give to the patient. We also give a taping, because sometimes a patient feel discomfort wearing like a corset or some orthosis during working. So we also think about to put a tape to the patient. At least it will reduce the pain and also reduce the swelling and also the inflammation and reduce the muscle spasm. And the good one is allow patient to remain activity even in their condition that have injury. So with the whole of this treatment, modalities, exercises, orthosis, taping, back to the case, actually we felt if we use the classical technique while a physician is become the center of the treatment. The fact is the pain has come back after 6 months. Even we already give, I think, many times or many sessions of treatment to treat the chronic pain. So from this case report, there are a lot of consideration if we treat a chronic pain. This is the thing that we learn from our past mistake. The first is about the sensitization. I think Dr. Rita already mentioned about the sensitization. Basically, sensitization is the increased responsiveness in level of either the spinal or the central nervous system. So there are two kinds of sensitization. The first one is the peripheral sensitization, which is the level of the spinal. The second is the central sensitization in the level of the central nervous system. I think central sensitization become more difficult to be treated if the patient or the chronic pain become the central sensitization. The second, we have to think about the pain perception, because the patient perception of pain is different between one patient into the other patient. Sometimes we have difficulty to decide, is it real pain or is only like the perception of pain, because there will be a different kind of treatment. The third is also the cognitive influences. Sometimes if the patient have like the past pain experience, it will also reduce the pain threshold, and finally the patient can getting easier to become a chronic pain rather than if this is the first case while they're getting pain. And the last, we also have to think about, should we treat the structural or we should treat the functional problems that become a problem? So for example, for these cases is, if we see from MRI, we know that the problem is on the disc L4, L5, and maybe it give a compression to the root of the L4, L5. So that is the structural problem. But because this is a chronic pain, sometimes the patient or the pain from the patient, it's not based on the structural problem. So we can imagine when a patient have low back pain, when we do MRI, the problem is on the disc and also from the nerve. But since it's a pain, so patient and also the body of the patient try to do some compensation. For example, like the muscle, we're trying to compensate with more contracting, and more contracting. But more contraction or over contraction of the muscle will also lead to become another problem. So it's a very fundamental to choose or decide, should we treat the structure or should we treat the compensation as the structural effect. So sometimes we don't really need to treat the structure, but we can only treat the muscle problem that become the compensation from the structural problem. Beside the chronic pain consideration, this is also the ICF, because in PMR field, we use the ICF concept to see the health condition. I think the physician center is being old, and now we adapt a new concept, which is the ICF concept. Because with the ICF concept, we can see the big picture of the problem, not only the function, not only the structural function or the structural problem, but we see the health condition, and it's also related with the activities, participation, environmental factors, and also the personal factor. The biggest thing beside the ICF, with ICF, we also put the patient and the family as the center of the treatment. It's different with the past treatment that we used before, that we are a center of treatment. Now we put the patient and family is a center of the treatment. So all of the team will see the patient is the center. So we try to support and we try to supply the demand of the patient that regarding to the chronic pain. So for this case, we can try to make the more specific with the ICF concept. So for example, like back pain, that back to my case report, the body structure and also body function. Here we can see there's a pain, there's also limitation of range of motion. There's also reducing in some activities like transfers, walking, balance, and also some participation like socializing with friends. And also personal factor is very important, also very influence the condition of the health condition, like the coping strategy, the weight of patient, and also other life factors and stressors. But for a chronic pain, especially for a worker, I think it's not really enough if we only try to see a structural or the biomechanical problem, but we also need to see and very specific to see about the activities or tasks that patients usually do every day while they're working, because that is the cause of the problem, that will be the cause of the pain, that if we cannot control the risk, then the pain cannot be gone for the future. So for this case, the environmental factor is very important. So if we see from here, repetitive activities like heavy lifting job is the case, or that is the big factor that really influence the health condition, which is the back pain. So even in PMR department, we have a lot of team. We do many collaboration inside of our department, but that is not enough. So we need the other discipline. Like in this case, we need the occupational specialist to set the working environment that will be suitable for the patient, and maybe some task modification that also very important for the patient, because that is the risk to become the back pain in the future. So based on this case, we learn and we improve our services, and now we use more specific assessment and intervention. So in our department, for now, for treating a chronic pain, especially a worker, we make a special clinic. So for example, like this one, we have the rehab spine clinic. This is very specific for spine, not only the doctor, but also all of the team that have a problem or have a program for the spine will also include in this team and also in this clinic. So we can see a problem not only from our perception, but all of many points. We also have like the hand rehab clinic. We also have the sexual clinic. Even we also have the rehab post-COVID clinic for a very specific exercise and also the program. But back to the problem here, we have a very specific assessment and also intervention. Besides the assessment, we also do a lot of the movement analysis. We try to analyze with the very simple method. How about their working? How about the movement? And how about while they're walking? We also do some specific exercises, not only like the range of motion exercises, not only like the flexibility exercises, strengthening exercises, but we try to make exercises that related to their working. So we do the stress testing or the exercise testing and also the exercise training, and it by the doctor, not only by the physical therapist here. We also improve our service with the interventional pain management and regenerative therapy, because sometimes the problem is not only the function but also the pain itself. So if we can treat the pain very good, the patient can come back to their work and also increase their quality of life. And the second is the regenerative therapy, because sometimes the overuse or the repetitive using of one structure will lead to a degeneration condition. So we try to do some adjustment with the regenerative therapy. For some problem like a tendon problem, like the joint problem, from our experience is quite good to treat the patient to reduce and to manage the chronic pain. But even we already done many treatment and improve our treatment, we also need to do some promotion, also mention about how to correct the posture, because the posture correction is very important to be done by the patient during their working. And we know if we can control and correct the posture, it will reduce many musculoskeletal problems that may be lead by the postural problem. We also give the proper body mechanism, because with the proper body mechanic, it will save for the patient, reduce the energy that needed by the patient, and also very efficient for doing the working. And also it can prevent the re-injury for the future. So even we've already tried to improve with the specific assessment, specific treatment, specific exercises, interventional pain management, regenerative therapy, and a lot of prevention and also promotion, I think it's still not enough to treat the chronic pain in a worker. So we need a bigger team to see a patient. So for example, in here, not only the PMR and also the team in our department, we also need the other specialists to in charge in also in treating the patient. That's why we have a collaboration with the occupational specialist to see a patient, not only a patient, but also a client that will return to their work. And also, I think we also need the multidisciplinary specialists, for example, like the surgeon and also the other specialists or the other team that can also help and support the patient to increase the quality of life. And last, because of we still have a lack of maybe technology and also the knowledge and experiences, and of course I think we also need the collaboration with the bigger field, which is the institutional collaboration. So with the sharing, with the transfer knowledge, transfer of the experiences, I think it will be very good to manage the chronic pain even for a patient and a very classic patient. So as the summary, the first summary, finding the source of pain, I think is a very good step to manage the chronic pain. Sometimes we confuse, should we treat the structure or the function, but analyze the source of pain. That is a good step to manage the chronic pain. So it's not like wasting time, wasting of money, and also the treatment, but we're very focused on the problem that's related to the patient. The second, there are no any single treatment to manage chronic pain, especially among workers. So many producer or distributor told me or told us, you can treat with this one, you can treat with this machine, you can treat with this equipment. But I think there's no one single treatment. But we need to see from the whole picture and decide what kind of treatment that will be the best for one patient. The third, a patient-centered approach is the key of success in managing chronic pain. So we change from the doctor or physician center, now we become the patient center because patient is our goal. The fourth is applying ICF concept in chronic pain will provide a deeper view about a patient health condition because we will get a big picture of the health condition, not only seeing the structure, not only seeing the function or also the activities, but we have the bigger view to see the health condition. And the last, the most important is the collaboration between the discipline, specialists, and also the institution will give a new hope in managing chronic pain among workers for the future. I think that's all from me. Thank you, Dr. Arya. Wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Ibrahim, for your clear and very, very to the point presentation. And now we proceed to the second speakers. And this will be different perspectives that we will have the communication with return to work stakeholder. Will be presented by Dr. Lailana Purvis. She is a medical doctor, specialized in both occupational medicine and also have a master in business administration. So she has a very comprehensive academic background, and she was graded from the Erasmus University from the MBA and for the Vrije Universiteit Amsterdam for medical doctors. So for Dr. Lailana Purvis, the chance is yours. 20 minutes, please. I'm sorry, the mic still unmute.
You should unmute first, Dr. Lailana. We still cannot hear your voice.
Is there? Yeah, okay,
yes, now. It's working now.
Thank you.
The only thing is I'm trying to find my file. And I should have done this before. One minute, please. Why can I not?
Or do you want me to help it for you?
Well, I don't understand why I cannot share. Why I can't find my file. I did it a few times. It's gone.
Okay. Okay. The committee already shared it. Yes. It's on the screen now.
Yes, thank you. Okay. Thank you very much. Ladies and gentlemen, thank you. And I'm very honored that we can do this together and start off with a continuous education between Indonesia and the Netherlands. And I'm very thankful that Professor Reneman and Dr. Rita have been participating, and we hope to continue this in a few in 1 or 2 months. And from another different point of view, as you know, most of you, I'm an occupational physician, and I'm also an insurance medical specialist. And I look at people who are going back to work, and how do we do this? How do we collaborate among each other? Can I have the next, please? Thank you. As my disclosure, I have no conflict of interest, but I do have an interest. My interest is that we do have a collaboration in scientific progress, and that we can work together and learn from each other. It's the best way to do things. We have been talking about the stakeholders. We've been talking about the stakeholders up to now, the different medical specialists. We have been talking about the workers, and yes, the employers have been mentioned, but how do we do this? Can I have the next one, please? If we look at the whole group of people who are involved, we talk about the patient, we talk about the employer, we're talking about return to work, but we're also talking about the human resource manager. We're talking about healthcare specialists, occupational physicians, case managers who are working on, and not to forget the insurers. Especially insurances is something that here in the Western countries is really has been developed quite well, and especially in the Netherlands, it's very difficult. It's different, much different than from other countries. It's almost organized and over-insured. I will not go into this further, but why I am mentioning is this, because we're talking about chronic pain, and I will in my continuing of my presentation, I will be talking about the reason why insurers are so important. So let's go back. Let's go and see who are those stakeholders. The patient. Can I have the patient, please? Okay, the patient. Yes, I agree with Dr. Ibrahim. It's the patient-centered care that we really need. And we have to listen to the patient. And we know, if you look from the ICF, we always look at the environment, we look at the person, we look at the individual, we look at the character. What kind of a drive does this person have? What kind of a motivation does this have? And talking about drive and motivation, most people are really hoping to be, they're very motivated. And they really want to stay at work because it's important for them. It's financially, it's important, but it's also for their status and their social well-being. And what you see, and it was mentioned before, we're talking about absenteeism, but we're also talking about presenteeism. And from different researches, they have found out that 50% of the patients with chronic pain, they show presenteeism. Okay, they're at the work, but they do less. And as long as nobody realizes, they will try to cope. The problem when they start coping is going to cost them energy, and at a certain point, there's a break point. So it's very important to be able to find prevention, that when these people have problems, that it will be well known to their co-workers and also to the employer. And if necessary and where necessary, the occupational physician can be consulted. And that is what we try to do, because we want prevention and we don't want to have to do secondary things. Another factor that also plays in the environment of the patient is the family. And how does the family cope, not only the individual, but how does the family cope with the problems that this person has? They all worry. And because if they don't work, it's a big problem. And one thing we have to realize is that the family has a lot of influence. If they stimulate each other, the person will be motivated and will have self-confidence to be able to continue in their work. If everybody pampers them and then they say, please stay home, careful this, careful that, they will be thinking, oh, everybody's doing everything for me. So it's quite difficult for them to kind of realize, like, okay, I can do more than I should be doing now. Can I have the next one, please? Okay, so we have the healthcare specialist. We've been talking about this. Dr. Rita has given the presentation, and Professor Reinemann also showed the research that has been done. And we are trying to collaborate. It is so important to be able to communicate, because what we do is, okay, as mentioned, it's either the general practitioner or one of the specialists that refer them to the rehabilitation center, but it can also be the occupational physician. And it is so important not to wait. As soon as we realize that these people need to be educated in problems about pain, as the sooner you get them to the right person, the better it is, and you can avoid a lot of problems in the future. What we also want to do is to be able to communicate with each other is because they have to know what kind of work does this person do, what is the workload. The person can explain, but also the occupational physician knows where this person is working, where we have to find ways to get these people to avoid certain problems. And then there's also the work consultant at the rehabilitation center here at the Beatrix Ward that also communicates with the person, and they do visit the workspace too. So we work together to be able to see how people are doing their work and how there will be a structural solution, because we want to avoid mitigating repetitive problems. Can I have the next one, please? So one of the challenges that there really is we do have to make sure that there's a good role clarification, because if we don't know each other's roles, there's a big problem that maybe one does happen, is that one of the people, the medical specialists, they will have a certain interpretation of what the people are complaining about. And one of the things that they will say sometimes does happen, it doesn't happen here in the rehabilitation center, but it does happen with others, that they say, okay, if this is fine, I've done the operation and everything, and yes, you do still have, but take it easy. Yes, you have this, we give them, you don't have to worry about your the problems that the MRI has been shown that there's not too many problems. There are a few things, but it's nothing. And the nocebo doctor, and then this patient is like, okay, what is happening to me and what's going to be happening? And then they say, okay, do things that you can, find your boundaries, find where the problems are, and take it easy. So take it easy means I have to stay home, and that's one of the things that you really do not want. And so during the rehabilitation of return to work and also the priority of early return to work, we have to make sure that there's a mitigating return challenges, because if something is recurring, then there's no continuation, and then there's going to be a problem. The employer might have very good feelings for this person, try to help out, but if they keep on getting back the same problems, then their credits are going to be less, and before you know it, he's going to lose the job. So, and also another thing is communication. We have to communicate. If we don't communicate and explain exactly, then we will have miscommunication, and that's the worst part that we can have. Can I have the next, please? So, as an occupational physician, we communicate with the employer, with the employee, and it is so important to be able to get them to realize how important it is to communicate with their worker. It's not only being there and that you have that you decide, that you said, okay, this is what I'm going to, this is what I'm offering in work, this is what I'm offering, as the employer says, I will offer you this money and that's it. No, we have to make sure that we help the employer to realize that they have to be able to give the person a meaningful, not just, we always say return to work and make sure about the disabilities that these people have, but it has to be meaningful. And it has to be, so you can do the production, you modify it, and you can also return the duties that are safe and that are in their capabilities. And that's where the occupational physician will come in to be able to explain what is the workload and what is the what are the disabilities this person has, what load can this person have at this moment. And it also has to be flexible, but because a person is flexible, sometimes it will go up and then they will feel bad a bit less, and then slowly but surely, as you all know, it's going up and up, just like a staircase. Communication with the injured workers throughout the recovery process and to confirm that they're valued is very important. The thing is, you have to make sure that the employer realizes they have to be able to give compliments. We all need compliments. If we don't get them, it doesn't feel right. And if you know that you're valued, you will do your best and you will have your motivation and your drive. And also make sure that the supervisors and the management have also been informing the co-workers. Don't forget the co-workers. And it's something that we always mention to the employer because they do forget, like, okay, this person is coming back, or as mentioned by Dr. Rita, okay, we don't want this person until he's just fine. No, this person is coming back. These are the problems. And of course, the person will also tell the co-workers what the problem is. But if it is explained and that they know, and that they are also that they work together and they participate together, it's going to help the person to come back to work. And even if the person doesn't do all the work, you can also divide and kind of redivide all the tasks that everybody has. Can I have the next one, please? As mentioned, the co-workers are so important, not only by informing them, and we also tell the employer, and that is why one of the things they have to be able to give a prognosis. Sometimes you can say, okay, I don't know the prognosis at this point, if this person will be able to come back to his own work. But we can say, okay, at least, in the first 4 or 5 months or 3 months, this person will not be able to do his whole job. Then the employer will know that he has to find another solution to replace this person who is disabled at this moment. And it's so important to make sure that they don't that the workload for the co-workers doesn't go up, that they will have problems. And so that's why an occupational physician is really important to be able to give this prognosis. And communication, of course, communication is always important, and we have to understand what kind of an injury they have, and what we are doing now, and especially communicating, what we're trying to help, as what Dr. Rita mentioned, at this moment at the University Medical Center, together with Beatrix Horst, we're going to start a research on how to make tools so that the employer and the employee will know more about pain, so that we'll have pain education, so that they know how to inform, and also how to in an early stage to see if somebody does have a problem and what could be the solution and whom to consult. And another thing for a co-worker is that a compliment is so necessary. And as I'm writing here, I said acknowledging and recognizing the contribution of the co-workers. You can give them a little present, you can give them a day off, an extra. It doesn't always have to be material, it can be immaterial, but co-workers will feel more appreciated if they do get something. It doesn't have to be big. And this is, and when the employer realizes this, you will see that the culture will change in the company, and people will be more motivated to help each other. So, and last but not least, I would like to give you the keys to a successful return to work. So we help and discuss this with the employer, but actually this goes for everybody. You have to be able to give somebody emotional support. You have to give them practical support. The emotional support is that you acknowledge that they have a problem, and that the person doesn't feel alone, that it's only his problem, but that somebody will be trying to help them. It will be starting from the doctor, starting from all the therapies that he's getting. It's from the occupational physician that acknowledges it's, and most important, it's the employer. The practical support is like what to do, how can we help? And for an employer, we always ask them, especially with chronic pain, allow sufficient sick leave, because if they start off too soon, then it's going to reoccur again and then again and then again, and it's going to get worse, and the employee will become insecure, and if somebody is insecure, you get into a depression before you know it. And it's so important to also make a good plan to return to work. So there's one of the tasks for an occupational physician, to help the employer and the employee make a plan on how to return to work, and in time and in workload. And sometimes it's important to be able to adjust the expectations, and you ask flexibility. If an employer is not flexible, there's a problem. And always assess workability in different ways to make sure that the person is doing it. And of course, appreciation. Appreciation is so important. It sounds simple, it's logical. We all say, of course, why should we mention it? If you listen to people and they and ask them, are you being appreciated? Do you get a compliment? No. And well, and then you ask the employer, why do you give? Yeah, I should. I forget. I know, I'm so busy. And it's the craziness of the day. So always keep on mentioning it. It doesn't, you can't mention it more enough. And always open communication from both employee and the employer. It doesn't mean that the employee has to tell them exactly their medical problems, but they do have to be able to tell them what are the restrictions that they have, and what are the what kind of problems do they encounter in their work, and which part of the work can they do. Before I end my short story presentation, I was mentioning the insurances. And we're talking here in the Netherlands, everything is insured. Health insurance is perfect. Everything is paid by the insurance company. And that, what isn't paid, we have, just like when we have the BPJS Tenaga Kerja, because if it is work-related, then there are other insurances that pay this. And in Indonesia, it's not everybody is insured yet, but one thing is sure, that the BPJS Tenaga Kerja will be paying more, and I think for getting workers back to work, especially for work-related problems. We're not talking about only occupational diseases, but also related, and especially we also have accidents, still many accidents, and that's where the insurance companies come along. And that what isn't paid by the healthcare insurance, then insurance companies come along. And actually, you don't want this, because just like in the States, you have everybody suing everybody and getting all kinds of lawyers. What you want to do is to be able to find ways to help the worker to be able to do his work, or to find another job, or to make a few adjustments to the job so that the person can do, or give them training, or give them an education. So realize that insurance is really important, because everybody wants to be sure of their income. Thank you very much. Terima kasih banyak atas perhatian, and I hope that this will help you to at least realize that it's so important to be able to communicate with the employer. It's not that they know everything, and they do forget a lot. Thank you.
Thank you, Dr. Lailana. That's very, very interesting, insightful, and I believe that it will trigger so many questions regarding here. We have a participant from either from the practice side and also from the managerial side. And then we will have the third speaker. This is from the practitioner side that we will have Dr. Iwan Susilo Joko. He's a alumni of the Master Occupational Medicine program and also Occupational Medicine Specialist Residency program. But now he is working as the Manager Medical Service in Chevron Pacific. So Dr. Joko will share experience regarding about the management of the chronic pain in workers based on the occupational aspect. So please, Dr. Iwan, 20 minutes for your time.
Okay. Thank you, Dr. Aya. Okay, I have shared my slide. Can you see my slide?
Yes, very clear. Please proceed.
Okay. Okay, thank you, Dr. Arya. Good morning and good afternoon, everyone. First of all, I would like to say thank you to the committee for inviting me to deliver presentation in this honorable forum. The topic given by the committee, which I will present today, is the occupational aspect of chronic pain management in worker. Let me start with the chronic pain is the pain that persists at least 30 days beyond the usual course of an acute disease or a reasonable time for injury to heal, and that is associated with a chronic pathological process that continuous pain. So there is quite a big sometimes for the acute phase to be a chronic pain. Maybe as the approach with the other condition, we will start with the taking history. First part of the history is the medical history, and then we should obtain the information as following, like general information, level of education, work history, current employment status, family environment, ethnic origin, activity of daily living, past and present psychology problem, history of disability, and also sleep disturbances. That usual as our aspect in the medical history. Second component that also important in the pain history is the history is the pain history. So the characteristic of the patient pain and also the patient response of the pain or to the pain is one of the key element in the treatment. We should obtain the site of the pain because the localization and distribution of the pain can help determine the type of the pain that the patient has. Then we use the pain score, maybe like Dr. Ibrahim said, is the visual analog scale for the intensity to determine the intensity, and also we should ask about, or we should know about the duration, place of onset, characteristic, and the response of the pain to the activity. So all the aspects should be included in the pain history. The third component of the history is the medical management history. We should also obtain the history of prior treatment, prior surgery, prior medication, psychological function, such as symptoms or depression or anxiety, or if there is any evidence of the stressor at the workplace or at home, or the past psychological problem that maybe can be contributing to the current state of the pain. And then the last component is the other affecting factor outcome, like maybe if you got some compensation or there is a disability or litigation, and also the treatment expectation. Maybe just example, we will know what does the patient expect from the treatment? Is there complete relief of the pain or just only the reduction to a more tolerable level? After taking the history taking, the next step will be the physical examination. We should do the neurologic evaluation to check the cranial nerve, muscle tone and strength, the atrophy, if there is any atrophy, and then also the motor neuron, also the reflex, and do the sensory evaluation, and the last also the musculoskeletal evaluation. The next box will be the supporting examination. There is 4 main evaluation. The first one will be the psychological evaluation. Psychological evaluation consists of the 2 components actually. The first one will be clinical interview, and then second one is the psychological testing. The result will help the treating doctor with a better understanding of the patient, and then also determine the further psychosocial intervention. And then in this case, the diagnosis using the DSM diagnosis should be determined and implemented. The next step, the next evaluation is of supporting evaluation is the laboratory testing. Laboratory testing can be used when there is a suspicious of the systemic illness, infection, or neoplasm, or underlying like autoimmune or rheumatic disorder, connective tissue disorder, or other parameters that need to be tested based on the physical examination. Radiology evaluation. Radiology evaluation such as the imaging, MRI, CT scan, bone scan, and then SPECT or other spatial imaging study may give us the useful information for many musculoskeletal disorder that causing chronic pain. Electrodiagnosis study also may be useful in the evaluation of the patient with suspected myopathic and neuropathic disease, and then it may be included like nerve conduction study or standard needle EMG, electromyography, or sometimes SSEP, the somatosensory evoked potential. The evaluation of the electrical study should be done by the well-trained neurologist. The next box is the patient education. Patient education play important role, like maybe Dr. Rita also said, and Dr. Ibrahim, the patient is the center of our treatment. Patient education is the interactive process where the patient not of the education of the first, the treatment plan. Second is the indication and potential aspect of the medication that he or she will get, and then also they should also educated about their home exercise program, and also the aspect of the result of the treatment, what tests to be performed, activity restriction and return to work status, how about the home management of exacerbation pain, and procedure for seeking care the exacerbation maybe after office hour, and then he got sick, he got pain. What is the procedure that also it is should be educated about that one, and how about the home self-maintenance program. Also, like Dr. Leilana said, that we should also educate about the patient responsibility to communicate with all medical provider and also with the employer for his condition right now. Educational effort also should target the family because family also will play important role, and other supportive person like maybe the case manager, also the insurer if he had the insurance program, or also to the employer as indicated to optimize the understanding of the patient and also the expected outcome. Overall, the patient education should emphasize the health and wellness, return to work status, and return to productivity life. The next box will be the treatment. there is a many there is treatment. We will divide it to the non-operative and also the operative. There is many non-operative method. One method that I would like to highlight is the formal rehabilitation program, which will meet the interdisciplinary approach. This program will provide outcome focus, coordinated, goal-oriented, measure and improve the function of the person, and encourage the appropriateness use of the healthcare system. The second, and then the next one, the treatment will be the medication. The medication. Maybe I will turn to the next slide. Wait. Okay. The medication that there is actually a common treatment for the chronic pain. We have one guideline. Maybe you can see in the left chart. We have one guideline from the workplace and safety about the pain management in occupational health. I would like to highlight there is three important things. The first one is the client education and avoidance of the over-prescribing is the key, eliminating the overuse of the narcotic. Second, about the goal. There is three goals of the pain management, which is to control pain, reduce risk of abuse, and reduce both direct and indirect costs related to the injury. And then third one, we should follow a stepwise approach in the pain management. We will usually use or follow the WHO ladder pain. Maybe you can see in the central picture. The initial medication usually we use is the non-opioid analgesic or NSAID, and then we increase to the weak opioid, and then continue with the strong opioid or transdermal patch, and then the last one will be some interventional treatment like nerve block epidural, or also patient control analgesia pump, neurologic block, or spinal stimulator. And as we know that the opioid may have significant effect that can impact to the worker. So ACOM has issued its guideline in 2014 that acute or chronic opioid use is not recommended for the patient who perform the safety sensitive job, like the driver, crane, heavy equipment operators, shop work, or work with the injury risk like working at height, or another task that involving the high level of cognitive and judgment. Then we will have also the many non-operative methods that maybe I want to highlight is the interdisciplinary approach program. Interdisciplinary approach program actually provide outcome focus, like I said, outcome focus, coordinated, and goal-oriented interdisciplinary that measure and improve the functioning of the person with the pain and encourage the appropriateness of the healthcare. Two methods that play important role in the occupational aspect actually is the work conditioning and work hardening. It will I explain in the next slide. And then the last part is actually the operative treatment, which is the surgery method, which depend on the cost. So all of the component here, starting from the history, physical examination, supporting patient education treatment, will play important role to the return to work of the worker. So as a doctor that handling the case, we should monitor all of the phase so it can work, or it can be we need to ensure that all of the section have the optimal approach, so the treatment goals will goes with plan. Okay, in this slide we can see the difference between the work conditioning and work hardening. Like I said, there's two methods actually that play important role. The work conditioning usually will recommend it when injured person has made consistent effort throughout the rehabilitation process. This employee need just only to overcome or fulfill the small gap in the functional performance to be able to work to their pre-injury job function without restriction. Like we see in the slide, the frequency maybe just only up to 4 times, can be extended to 8 weeks, and then the frequency is 2 up to 5 days in a week, and then the duration around 1 up to 2 hours a day. The objective is to improve the cardiopulmonary and musculoskeletal function. And in this method, actually work stimulation not included and only focus on the fitness level. The progress just only measure about the fitness level. Meanwhile, the work hardening program is actually highly structured intervention that utilize the multidisciplinary teams that provide services. The goal of the work hardening actually to improve the injured person to the highest possible functional level. See, the employee in the work hardening maybe participate up to 8 weeks, up to 8 hours a day, 2 up to 5 days in a week, and then can be extended up to 8 weeks. So usually 4 weeks, but we can extend it up to 8 weeks. In this program, work stimulation will be included in the program, and the job requirement will be used as the objective. So the progress for this program will measure using the incremental tasks that can be done by the worker as per the job description given to the program, work hardening program. Okay. How do the return to work evaluation do? So the return to work actually is the one major component in the chronic pain, because a prolonged time of work will decrease the likelihood to return to work. First treatment is really crucial in the preventing of the chronicity and disability mindset. There will be a 7 part actually of the return to work evaluation. Like following is the identify detailed job description, and then we review the job demand, including the physical aspect, also the motoric aspect, workplace aspect, organizational aspect, sensory aspect, mental aspect, and etc. We also need to assess the current health status, including the general status, and then mobility status, motoric status, body posture, skill, and prognosis. The fourth one, we need to establish the impairment, disability, and handicap status of the worker. And then we should consider the risk to the patient, to the colleagues, and to the workplace. And we need to consider the tolerance in the workplace from worker and supervisor or work colleagues. The last one will be determine the return to work status. The next slide in the next slide I will explain about one case example that actually we have. Actually, this case is quite same like I saw in the chat. Maybe I forgot the name that with the FEBS. So this case actually 52 years old, male, worked as the operator, came with the numbness in the lower leg radiating to the toe since 4 years ago. The pain actually started in 2011 and then had some treatment, including medication and physical therapy, and also the surgery. After the surgery, the pain actually was manageable but came back again in 2014. And then EMG showed the radix intervention. They did again the surgery. Unfortunately, the symptom just a little bit decreased. and then the worker still have the debilitating pain, so the treating doctor must do the CODA block and neurolysis. This condition right now is still with the symptom with the PS score 6 up to 7, managed with the NSAID and opioid. We diagnosed him as the lumbar SNP and with the failed back syndrome surgery. So what is the job description? Actually just operate the shipping pump, genset, and hourly monitor shipping pump and routine check the pump house. The job demand, the physical demand is 5 mats and occasionally lifting and carrying 23 kilos. It is based on the FCE like like Prof. Michelle mentioned. They did actually the FCE evaluation and categorized as the occasional lifting and carrying 23 kilos. The job demand should require the good mobility and also full motoric strength. The current status, like I said, is pain, intermittent pain with the VS score 6 up to 7, and then good motoric strength. And he currently took the NSAID and opioid medication. There is impairment, disability, and handicap, and there is the sum of the job task can aggravate his condition. But the tolerance, actually, the worker can accept his limitation and or limited condition, and then he hope that he can return to work as well as his supervisor and his colleagues. The return to work status of the return to work status of this case is the fit with restriction and not doing the we give the restriction that restrict the carrying or lifting activity. What is the lesson learned of this case? Actually, this is quite a difficult case because there is some organic causes that make this is complicated case. After several surgery, the pain is still there, but yeah, we just give the patient the NSAID and opioid. We learned that this case is not yet undergone the optimal rehabilitation at the early onset of the disease, and as the final result, he has to have some restriction in his job, the carrying or lifting activity. Maybe if we can do differently, we can do better case management at the early onset. Probably he had the different outcome of this case. Okay, I think
one minute.
Yes, this is the final one. I think this is the final slide. So worker with the chronic pain will my take home message is the worker with the chronic pain will need interdisciplinary coordination or collaboration and rehabilitation program, so workers can return to work as soon as possible. The doctor or the case manager that managing the case should monitor the case starting diagnosis, early diagnosis, and ensure that the worker get the optimal treatment and rehabilitation. And the return to work assessment will need to be done before worker come back, returning workers to the previous position, so the worker can do work safely. I think that's all from me. Thank you, Dr. Arya.
Thank you, Dr. Iwan. So I'm sorry that we are having a little bit of time straining here. So we have the question and answer session now. And I think the committee already provide us the list of questions. I see that so many questions arise, but because of the limited amount of time, so I give the chance to the speaker maybe to choose one or two the most interesting or the most challenging questions. Yeah, but because some of the question comes earlier, so it's up to the speaker if you want to choose the first questions in order. So this is for Dr. Ibrahim. Committee. Okay. So, Dr. Ibrahim, so what is your decision? Maybe you can choose 1 or 2 questions. So we are sorry because of the limitation of time. I see that so many questions comes to you, Dr. Ibrahim, but it's up to you.
I think this 2 question is a good question, so I will answer this 2 question.
Okay, please proceed.
Okay. The first one, thank you, Dr. Lailana. It's a good question. In Indonesia, we have 2 kind of the national health insurance. The first one is the common national health insurance, or in Indonesia we call the BPJS. And the second one is the national health insurance for the workers. So for national health insurance for workers, actually will cover all of the demand for the patient or a client. So either the orthosis, even the prosthesis, even we give a very good prosthesis with very complex and also very functional processes, it will be covered by the National Health Insurance for Workers. So it's a good thing in Indonesia. For the second question, failed back surgery syndrome is a very common condition. So if we only see the structure, sometimes a surgeon actually, when we see the MRI and also see the result from the patient, we'll see if we treat the structure, for example, surgery, the pain will gone. But the fact is not like that. I mean, even with they try to cover or take out the compression of the nerve by the dissectomy or any kind of surgery, sometimes the pain is still there. So based on my presentation, I think the most important is we have to find what is the source of the pain. The second, is it related of working or not? If it's related to the working, then you need to do some adaptation with the working and also the functional capacity evaluation. Should they return to their work or they have to change the position or working? If we can treat the patient and we see the whole problem from the patient, we hope it will be good for the patient. Not only the medication, not only the physical therapies, not only the surgery, but what is the cause of the pain. I think that is Dr. Arya. Thank you.
Thank you. So, despite of so many questions, we are sorry that Dr. Ibrahim only have an opportunity to ask 2 most prominent questions. So then we have for Dr. Lailana. Dr. Lailana, I see that you have several questions also, but this is the questions that rise first. For prolonged sick absenteeism in chronic pain, this is from Dr. Bayu Surya Haji. Indonesian Health Resource Department in the company use the prolonged sickness program. Okay, this allows the patient to have 1 year sick leave opportunity to get optimal medication. Okay, but unfortunately that after 1 year, the company may release the patient from the employment status. That's too bad. How can we get opportunities for this situation? Do you have any comments regarding to this situation, this scenario, Dr. Lailana?
Yes, Dr. Bayu, thank you for the question. It's quite an important one. Yes, in Indonesia, sometimes it's 1 year depending which company, and sometimes it's even 2 years. Here in the Netherlands, it's always 2 years that the employer has to keep the employee employed. In that time, it doesn't really matter how long, but the sooner we want prevention, but the sooner we find people with chronic pain that causes absenteeism, it is so important to get a good view of the prognosis. And the moment that you realize that, even with, just like what Dr. Rita said, and also what Dr. Ibrahim says, you can do a lot of things and help people to return to work. But there's also a problem of time and certain positions. You do have to realize the sooner you know that this person will not be able to do his or her job fully, you have to find a solution. And is the solution in that same company? You do hope it. That is the possibility. Otherwise, you will have the employer, together with the employee, will have to try to, and the employer has to try to help the employee to give them the opportunity to find another job. because hanging on, sticking in there, and then like hoping, and then after a year, then you have this very depressed person who is striked out with anxiety and insecurity. So the moment that you know what are the prognosis is, and that's one of the roles that an occupational physician that has, to be able to communicate together with the employer, with the employee, with the employer, and also with all the health specialists that are trying to help him or her to get a better quality and quantity of life. And so those are the opportunities that we really have to look for.
Okay. Do we still have another question for Dr. Leilana?
Yes, I saw this one. Thank you, Dr. Marcin.
Yeah, maybe. Okay, maybe, yeah, from Dr. Marcin.
Yes. Well, this what Dr. Marcin says, based on your experience, how sufficient? Yes. When is sufficient? Very good question. We always try to find objective means to be able to give a definition of sufficient, but it doesn't really work. It depends. It's always trial and error. But on the other hand, we do know what the problems are, what the prognosis is, and together with the with a rehabilitation program, and if you work together with the different interdisciplinary settings, you have to try, just as I mentioned, you have to try to find a good balance for this person. The sooner this person finds a new balance, a balance that he or she will be able to accept in a better way, to be able to cope with it in a better way, then you will see when what is the next result. Can this person go back to his work, and is that the goal, or do we have to find other solutions? I hope this answers your question, Dr. Marcin.
Thank you. And for Dr. Iwan, that we have 3 questions in the screen. So it's up to you. We have a question from Prof. Michelle and Dr. Rita himself, and we have also from Dr. Boy. So it's up to you, Dr. Iwan, which one that you want to respond?
The first one, never specialist refer to surgery. Okay, actually for Dr. Boy, it depends, Dr. Boy. Usually we will refer to the orthopedic surgeon, orthopedic with the spine specialist, spine subspecialist first, if there is no involvement in the neural part. So if there is involvement in the neural part, maybe we can refer also to the neurosurgeon. That is the first one, Dr. Arya.
Yes.
The second one, and functional.
Yeah. This is a challenge actually.
Yeah.
From Prof. Michelle.
Okay. Yeah, maybe Prof. Michelle. I think the FCE itself actually can. The FCE actually the examination that determine actually the capacity of the worker itself. So if it's done before the injury or before the pain, so it can help us to understanding the capacity of the person that he have. Then we matching with the job demand right now. But right now for the capacity, if injured, I think we can do the functional capacity evaluation, but maybe in the really cautious way, because there is some in the functional capacity evaluation, we measure also about the pain and also monitor about the vital sign. So when there is increase in the pain and the monitor of the vital sign, we can stop the functional capacity evaluation. And then if the worker cannot meet with the job demand based on the standard, the FCE, yeah, I think he cannot pass the FCE test, and then also the physical demand based on the FCE cannot be fulfilled in this case.
Okay, so the third one, okay.
It can
involve family in the treatment.
Yes, the third one can in what way actually not in the treatment, maybe Dr. Rita, maybe in the patient education. We educate the family to understand the patient condition, so the family can help to encourage the patient to fulfill like the scheduling or the scheduling appointment for the rehab program. Sometimes the patient have reluctant to do the program. Maybe as we know, if there is a quite long rehabilitation program, and then sometimes he feel sick, he feel pain with the program, he is reluctant to do the program again. So we need the family and other support person to encourage him to continue with the program, to be successful, and then can be ready to work. That's Dr. Arya.
Okay, thank you, Dr. Iwan. So I can conclude that here we have so great response from the participants and so many challenging questions. And this indicates that we have a very promising topics that we can discuss and for the continuation of this webinar, because we plan to have the continuation of the seminar at May, and the exact dates will be announced by the Dr. Marcen. Yeah. So I think maybe this limited time is not enough, but I see that some of the speakers has declared the email for further communication, like Dr. Ibrahim. So feel free to contact. And also thank you very much. This is very insightful from Dr. Ibrahim, Dr. Lailana, and Dr. Iwan. And I see that we have a very promising collaboration for the future, not only for the continuing medical education like this, but also for the research also, yeah, and also for the improvement of the treatment. I see that there is a lot of challenge from Prof. Michelle to use innovative approach for the treatment. So I think that's all from me. A big gratitude and applause for the speaker, Dr. Ibrahim, Dr. Elena, and Dr. Iwan. And thank you. I give back to Dr. Marcen. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Arya, for moderating the second discussion. So, everyone, we have finally reached to the end of this webinar. I would like to thank all the speakers and also the participants that have made their time to attend this webinar. And as the conclusion, maybe I can make a little bit conclusion that for management of chronic pain, we have to make a collaboration between treating doctors, rehab doctors, and also occupational medicine specialists to work hand in hand together to make a good outcome for the patient. And before we really end this webinar, I would like to remind everyone that to obtain the certificate for this webinar, you have to do the post test. The link has been posted on the chat box, and the link will receive answers until tomorrow afternoon at 12 p.m. I think that's all from me. Oh yeah, and for the next series of this macro webinar, we are planning to have the next webinar in May 29th, 2021. It's also on a Saturday afternoon like this, 2 p.m. until finished. I think that's all from me. And before we really end this webinar, I would like to invite to all of you to turn on your camera, because you are going to take the screen capture for everyone. So maybe the committee can help me to capture, to give like countdown to start the screen capture. Maybe Dr. Itro, can you help me?
Yes, Dr. Marcen.
Yeah, can you help me capture the participants?
Okay, this is for the documentation. We are going to take some pictures. Okay, everybody, please turn your camera on. Okay, and put your smile on also, don't forget. Okay, we have several pages here. Okay, the first one. And then the second one. Okay, the third. And then the fourth. 5 page, 6 page,
a lot,
7 page, and the last one, the 8 page. Okay, we are sorry for the YouTube followers that we cannot take pictures, but we believe that the post test and the attendance list will help us to get the figures how many attendance from the YouTube. Thank you.
Thank you, Dr. Yitro, for helping us document this event. So that's the end of today's webinar. I'll see you on next event. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi.
Thank you.
Thank you, Prof. Michelle.
Thank you very much.
Dr. Rita,
Thank you.
Dr. Layana,
Thank you.
Dr. Iwan,
Thank you very
Dr. Rita.
much.